Secretary Mr. Vikrant Indore sir, AMD Dr. Sandeep Shukla sir, principals, deans, and faculty members of various nursing colleges and VGI colleges, clinical staff, and dear students. I warmly welcome you all in first National Virtual Conference of Vikrant Institute of Nursing and Science, which is organized on the theme Medication Error, a Major Lookout to Nursing. This topic I have selected to keeping in the mind the learning enthusiasm of nursing students and clinical nurses, because as statistics tells that medication error comes under 10 leading cause of death worldwide, and most of the concern has with nurses. So today we are very fortunate to have very eminent and learned resource person for this conference, and I hope that this conference will be very successful and all the beneficiaries will get it benefited. As we know that Goddess Saraswati is an authority of academics. Without her blessing, nothing is possible. So before begin this conference, I would like to pray Ma Saraswati. Let's begin with Ma Saraswati prayer. Is it visible to all?
Yes.
Today, Vikrant Institute of Nursing and Science, Indore, welcomes you all on the first virtual national conference, July 2020. I wish that all my resource persons and eminent speakers would have come to this campus, but due to COVID lockdown situation, they all could not come to campus. So before starting this session, they should get acquainted with our institution. So let's have view of our campus. Vikrant Group of Institutions is our chairman, sir, Mr. R.S. Rathore, sir, a visionary leader and chairman and founder of Vikrant Group of Institution in Indore and Gwalior. VGI, Vikrant Group of Institution, came into existence in the year 2007 to shaping young minds through quality education by opening College of Engineering and Management in Indore and Gwalior. Nursing College has started in year 2018-19. At present, we have 2 batches of BSc Nursing with annual intake of 60. This is our head office situated at Gwalior. This is our corporate office situated at Gwalior. And head office is that this is our new head office inaugurated on 2nd July 2020 in Gwalior. And this is our Gwalior campus. This is our view of our Gwalior campus. And Indore, this Indore campus. This is Vikrant Institute of Nursing and Science, Indore. The courses we offered at Vikrant Group of Institution are nursing, paramedical, engineering, management, law, polytechnic diploma, PGDM, PMKVY Center. Vikrant Group of Institution is a center for PMKVY and NSDC approved center is our VGI. This was all about our campus in short introduction, but as our audience are very enthusiastic and want to know detail about today's speakers. Today we have very learned and eminent speakers to enlighten our audience. So before beginning session, I wish to introduce my all speakers one by one to our management bodies and our audience. Today, we are fortunate enough to have Brigadier Dr. Kamlesh Singh Madam. Brigadier in Military Nursing Services, Dr. Kamlesh Singh Madam is having 40 years of work experience, out of which almost 36 years she has served to Military Nursing Services. Madam is a former principal of National Institute of Medical Sciences, University College of Nursing, Jaipur. Recently joined RD Memorial College of Nursing, Bhopal as a principal. Madam's professional qualifications are, she has completed her PhD from NIMS University, Jaipur, Rajasthan, Masters in Community Health Nursing from LT College of Nursing, Bombay, SNDT University, and graduation from College of Nursing, Armed Forces Medical College, Pune University in 1979. Madam's professional achievements are innumerable. Few I have highlighted here. She has rich experience in all positions of the ladder. An enthusiastic nurse researcher, has completed 2 nursing researches as principal investigator, being funded by the DGAFMS Government of India, has several research publications to her credit. She has been teacher, guide, and examiner in various universities. Madam is the Inspector of Indian Nursing Council and University and has contributed a lot to the advancement of academic environment. Madam was awarded with the Commendation Card Exemplary Services by the HQWNC Mumbai and awarded as a Best Teacher by Trained Nurses Association of India Rajasthan branch. Thank you so much, Madam. We are enlightened to have you here. Madam will give keynote address on today's topic.
Thank you.
We have another speakers with us, Dr. Ashok Mewada sir. Dr. Ashok Mewada sir is our supporting hand and always with us. Dr. Mewada is a renowned chest physician of Indore City, consultant of industrial health, occupational health, physician and TB specialist, HIV AIDS medicine, practicing in HIV AIDS medicine, having more than 40 years experience in the field of medicine. Sir is giving free services to poor and needy with the thought, lot of things we have taken from society, let's return it back. Sir is associated with many voluntary organizations and organizing free health camps periodically. Sir has big contribution to alleviate sufferings of from the community. He is a great doctor and excellent human being. We are fortunate enough to have you with us, sir. And sir is going to give overview on the topic. Our next resource person is a very eminent and learned Dr. Pramila R. Madam. Madam is presently working as a principal Chirayu College of Nursing, Bhopal. Madam have total 26 years of experience in various positions and places. Madam has done her PhD in 2016 from Nitya University, Mangalore, Masters in 2001 from KMCH College of Nursing, Coimbatore, Tamil Nadu, and BSc Nursing from Holy Cross College of Nursing, Tiruchirappalli, Tamil Nadu. Her professional achievements are many more. She has published 50 articles in national and international journals, presented 28 papers in state, national, and international platforms. Madam is the author of 2 books which are very popular in nursing students. That is Pocket Book on Laboratory Tests for Nurses, published by JP Brothers Medical Publisher in July 2008, and Nursing Communication and Education Technology in February 2010.
Hello.
Madam is an editor-in-chief of 2 journals and national editorial member of 7 journals.
What I could do?
Madam is a member of ethical committee in Madhya Pradesh Medical Sciences University, Jabalpur, serving as a chairperson in Research Advisory Committee of Chirayu College of Nursing since 2016. We are very fortunate to have you with us, Madam. Madam will speak on causes and types of medication error and also present some research evidence on it. Thank you, ma'am. We have another renowned speaker with us, Dr. Mrs. Sadhana Upen Adhyapak, a highly motivated and dynamic faculty with 23 years of experience. Madam is presently working as a professor and head of the department at D.Y. Patil College of Nursing, Pune, and also have been worked in various positions in different places. 3 years of clinical experience she has in Leelavati Hospital, Mumbai, and Bharti Hospital, Pune. Madam has completed her PhD in 2016 from Dr. D.Y. Patil Vidyapeeth, Pune, and Masters in Medical Surgical Nursing in 2006 from Bharati Vidyapeeth Deemed University, Pune, and BSc Nursing in 1996 from Pune University. Madam's publication and professional achievements are: she has published 10 articles in various journals, presented paper in national and international conferences. Madam is awarded as a best educationist from Trained Nurses Association of India, Pune City branch in May 2014, and a source person in many national and state workshop and conferences. Madam is life member of Trained Nurses Association of India, Critical Care Society of India, Nursing Research Society of India, and Alumni Association of Bharati Vidyapeeth College of Nursing, Pune, Alumni Association of Dr. D.Y. Patil College of Nursing. We are lucky to have you here, Madam. Madam will speak on working to reduce medication error and what to do if medication error occurs.
Thank you, Madam.
Thank you for being with us. We have another resource person, Mrs. Dolly Biswas. Madam is a Chief Nursing Officer at Fortis Hospital, Anandpur, Kolkata, having 22 years contribution in clinical education and nursing administration. Madam has done MPhil nursing from Manipal University in 2008 and MSc nursing from West Bengal University of Health Sciences in 2003. Madam has done Young Leadership Development Program from IIM Ahmedabad and Fortis Academy Leadership Training from Singapore. Professional achievements are many. She is a NABH assessor for entry-level healthcare organization. Achieved Nursing Excellency Certificate from Quality Council of India and done independent audit and set standard for various nursing procedures. Received Win Nurse Influencer Award and Star Performer Award from Fortis Healthcare Organization. She has published first heart transplantation by Fortis in Eastern Journal article in Trained Nurses Association of India Journal in December 2018. Paper in different conferences and workshops. Madam is a life member and associated with many organizations. Member of Trained Nurses Association of India, member of Nursing Research Society of India, and member of Critical Care Nursing Society of India, GC member of Infusion Nursing Society of India, and member of ANEI, and member of CAHO. Today, we are very, very lucky to have you all here in this platform. So I hope all audience and my management personnel will get acquainted with you all. And here I request my group director, Dr. Satyanarayan A. Sir, to deliver welcome address. Over to you, sir. Sir, can you hear me?
Yes. Good morning. Good morning. Can you hear me clearly?
Group director, sir.
Can you hear me?
Yes, sir.
Yes.
Sir, can you hear me?
Yes, yes. Good morning. Vikrant Pranam to all. We had just few weeks back a research committee meeting with Kashkari Sharma ma'am, and she told that she wanted to start this national workshop on the
Group director,
medication.
sir.
Yes, can you hear me?
Yes, sir, we can. That's
Yes.
fine.
Sir was connected earlier, but due to some technical problem, I think he could not
Hello.
Ma'am, he's
reach.
there online. He's speaking.
So I request, without wasting my time, I request our respected chairman, Sir Mr. R.S. Rathore, sir, to sir, please say few words and bless the gathering.
बेसिकली मुझे लगता है कि जीडी साहब अभी लाइन पे हैं एंड आई एम एबल टू हियर हिम. पहले उनका कंप्लीट करा लें.
He is very well heard.
Yes,
Seen also.
yes, sir.
बेसिकली मेरी आवाज सुनाई दे रही है? बेसिकली
Group director sir, sorry
Yes.
sir, I think group director sir is connected.
Yes.
हाँ.
Okay. We
Sir,
had
you are
this.
connected with us?
Yes, sir. Yes, ma'am. We are there. So we had this research meeting, and then there was a proposal to have this national conference, and we immediately agreed, and that's where we are now today. I'm very happy to invite all the eminent speakers, doctors from all over
Sir,
India.
we cannot hear you. Are you connected with us, sir?
Yes. You can't hear me?
I think, sir, it's the internet
Sir,
problem. I
due
think
to
ma'am can't
technical
hear you.
problem, I think sir is not coming. So again, I request our chairman, sir. Sir, please proceed.
No, ma'am, everyone can hear him very clearly. आपको ही सुनाई नहीं दे रहा है. बाकी rest, I think we all can hear him and see him also.
चलिए सभी लोगों को सुनाई दे रहा है.
हाँ.
आपको सुनाई दे रहा है कि नहीं?
So
please
continue.
Yes. So
Okay,
medication error is one of the key areas.
Chairman, sir, go on mute.
She was much concerned, and she wanted to take this for our nursing students, and that's the main objective of having this national conference. We have an eminent speakers and resource people from all over India to deliver this talks and make this conference very fruitful. I welcome all of you, sir.
Yes, sir.
Chairman, sir, please.
Yes, please. नितिन, मुझे लगता है केशकली के साथ कोई टेक्निकल प्रॉब्लम है.
I think it's the internet issue might be there, but we can continue. I mean, I request
Yes, now I can hear you, sir. Yes.
Okay. Thank you, केशकली. आज के इस राष्ट्रीय संगोष्ठी में उपस्थित, जो कि पहली बार मुझे लगता है कि इतने व्यापक पैमाने पर ये प्रयोग किया गया है, और एक ऐसे महत्वपूर्ण विषय पर विषय विशेषज्ञ के रूप में हमारे साथ आज 5 बहुत अच्छे वक्ता, जो कि बहुत अनुभव है, और वो सब जुड़े हुए हैं. विक्रांत के लिए ये गौरव की बात है. और जितने भी लोग हमारे साथ जुड़े हुए हैं, चाहे शिक्षक वर्ग हो, चाहे विद्यार्थी वर्ग हो, इन सभी को आज के इस व्याख्यान से, इस संगोष्ठी से बहुत लाभ मिलने वाला है. ये विषय ऐसे मौके पे आपने चुना है कि द मेडिकेशन एरर, आपकी एक एरर नर्सिंग प्रोफेशन या डॉक्टर्स, जिनको कि आज हम मसीहा बोल रहे हैं और धरती का भगवान बोल रहे हैं, आप लोग धरती के भगवान हैं. आपकी एक त्रुटि एक व्यक्ति के जीवन से खिलवाड़ कर सकती है. इस विषय को इतने बेबाक तरीके से आपने चर्चा के लिए चुना. मैं आयोजक हमारे नर्सिंग कॉलेज के आप सभी को बधाई देता हूं कि ऐसा विषय जो कि बहुत बेबाक है, और इसमें एक खोज करने की आवश्यकता भी है. एक नया लुकआउट कि क्या हम खोज कर सकते हैं कि कैसे हमारी त्रुटियां ना हो, जिससे कि मानव जीवन की रक्षा का जो वचन आपने लिया है, संकल्प लिया है, वो पूरा हो सके. विषय विशेषज्ञ के रूप में हमारे साथ उपस्थित डॉक्टर अशोक मेवाड़ा साहब, आपका सदैव हमको स्नेह मिलता रहा. विक्रांत को आज हमारे साथ बहुत वरिष्ठ डॉक्टर ब्रिगेडियर कमलेश सिंह जी उपस्थित हैं, डॉक्टर प्रमिला जी, डॉक्टर डॉली विश्वास जी, डॉक्टर साधना अध्यापक जी. इतने विषय विशेषज्ञ देश के विभिन्न कोनों से हमारे साथ उपस्थित हैं, और एक ऐसा सामान्य विषय, भले ही तकनीकी दृष्टिकोण से ये स्वास्थ्य से संबंधित विषय है, लेकिन मुझे ऐसा प्रतीत होता है कि ये विषय सामान्य रूप से हम सभी इससे लाभान्वित होंगे कि मेडिकल की त्रुटियां हमारे जीवन के लिए कितनी घातक सिद्ध हो सकती है. तो आप इस विषय पर मैं चाहूँगा जितना भी मुझे समय मिलेगा आप सभी के व्याख्यान से मैं लाभ लूँगा, और स्वयं भी लाभान्वित होऊंगा. जितने भी हमारे साथ लोग जुड़े हैं सभी से अनुरोध करूंगा कि पूरा सेशन बहुत तन्मयता से और ध्यान से सुने. बहुत शानदार प्रदर्शन होने वाला है आज, और आज ये वर्चुअल नेशनल कॉन्फ्रेंस आपने आयोजित किया, इसके लिए मुख्य आयोजनकर्ता श्रीमती केशकली शर्मा जो हमारी प्रिंसिपल भी हैं, और विक्रांत इंदौर का समस्त प्रबंधन तंत्र जिन्होंने इस कार्यक्रम को मूर्त रूप दिया है, और हम सभी देश के विभिन्न कोनों में बैठ करके आज इस विषय पर व्याख्यान सुनेंगे। मैं इतना ही बात कहकर अपनी बात समाप्त करूंगा और आयोजक से निवेदन करूंगा कि व्याख्यान प्रारंभ करने के सिलसिले में आप कार्यवाही करें। और चूंकि आपने सरस्वती वंदना से ही प्रारंभ किया है, तो मुझे पूरा विश्वास है कि माँ सरस्वती आज की इस व्याख्यान माला को, इस संगोष्ठी को बहुत सफल बनाएंगे। धन्यवाद।
थैंक यू सर।
विक्रांत,
थैंक यू सो मच सर। आपके ये वर्ड्स और आशीर्वचन सुन के अब मुझे भरोसा हो गया है कि सच में ये बहुत सक्सेसफुल होगा। थैंक यू सर, थैंक यू। और जैसा कि सर ने कहा, विदाउट वेस्टिंग माय टाइम, हियर आई एम गोइंग टू बिगिन द सेशन, एंड द फर्स्ट सेशन, that is keynote address. For keynote address, I invite Brigadier Dr. Kamlesh Singh Madam. Madam, please come and proceed with your topic. Over to you, Madam. Madam, you can unmute yourself.
Hello, good morning. Good morning, everyone.
Good morning, ma'am. Welcome you, ma'am.
I hope you all can hear me.
Yes, ma'am.
I take this opportunity on it's sunny over here, sunny morning over here in Jaipur, to really thank from the bottom of my heart Vikrant Institute of Nursing, the management, especially for hosting this particular conference at a national level during the pandemic COVID 2019. I am really grateful for being honored to come and speak as a keynote addresser. This is a very important topic, medication error, and especially with relation to nursing, because today we see many things in our country happening, but errors are not reported as often as they should be. Happiness is the new rich. Inner peace is the new wealth. Kindness is the new cool. Good morning, everybody. The dignitaries on the dais, off the dais, principals, loving students, and all those who are attending this conference. Nursing is known to be a scientific profession based on research, theory, and concepts, centered on the art of caring and focused on healthcare outcomes. Nursing is composed of a diverse set of practices and functions, each requiring specialized knowledge and skills. We have the great Florence Nightingale, who said that nursing is an art, and in fact, she mentioned that it is a fine art, and almost she said that it is the finest of fine arts because no preparation which is so hard can prepare anyone for having to do on human beings. I quote Florence Nightingale. What are errors? Mistakes of life? They are facts of life. It does happen. We are human beings, but it is a response to errors and learning from the same that counts. And I unquote Nikki Govani. A brief overview of the topics: introduction, definition, epidemiology, nursing error with medications, patient safety, various aspects of medication error, COVID-19 pandemic scene, nursing responsibilities, legal and ethical, research findings on medication errors by nurses worldwide, implications for nurse administrators and educationers, and conclusion. Before I start, I would like to say that most of the top parts would be dealt by the various speakers. So I have given an overview and highlighted only the key important areas. Medication error scenario in India. The prevalence of medication errors is mostly underreported due to reasons, sparse data on medication error, and only few studies have been done. Only hospitals, those who are looking for healthcare accreditation, are practicing or have a system to look into the medication errors problems. The health professionals are not trained to detect medication errors. The lacuna exists in the system of drug delivery from prescription to administration of the drugs to the patients. In the fast-paced health and care environment, nursing performs the highest risk task of medication administration. Therefore, I introduce that medication errors may occur during any phase of the medication process: prescribing, transcribing, dispensing, administering, monitoring, and reporting. Some harm caused by medicines is due to errors that are preventable. Hospitals and health services aim to prevent the harm by understanding what contributes to these errors. There are various definitions of medication errors. I have taken up a few. As per the National Coordinating Council for Medication Errors Reporting and Prevention, it defines medication errors as any preventable event that may cause or lead to inappropriate medication use or harm while the medication is in control of the healthcare professionals, patients, or consumers. Mistakes occur when healthcare professionals do the right things in the wrong way. This is the big thing that we need to understand. A medication error is a failure in the treatment process that leads to or has the potential to lead to harm to the patient. Epidemiology of medication errors. We don't have much data, but whatever I could gather, I found from the national figures that incidence of adverse events was as high as 82 out of 1,000 prescriptions in Delhi. And the national figure reports up to 5.2 million medical errors. Medical errors include all types of errors. And within that, medication errors also come. In India, the incidences of medication errors were reported by state government of Uttarakhand as 26% and Karnataka as 14%. Clausen et al. Found a high rate of medication errors, 42% in a study in Sweden. And they said that most of these errors were preparation errors and others were due to an incorrect dose taken by the patient. Nurses play an important role in medication administrations. Hence, this topic is very important to be understood by all. Nursing error. Nursing error, an operational expression which happens because a planned chain of physical and mental actions fail to reach the goal in treatment or in health promotion, etc. This failure cannot be attributed to the intervention of chance. This type of errors results in high morbidity and high mortality, in addition to large sums of treatment costs annually. Nurses and medication errors. According to the Institute of Medicine, medication errors are among the 5 categories of medical errors. Medication administration is one of the most important duties of nurse. It requires a particular set of knowledge and attitude if it is to be implemented correctly. Medication errors can put nursing practice at risk and can create preventable risks for patients. We must understand, students who are gathered here, that there are 2 things we must understand, and one is error of omission, if we omit. And what does it mean? It's a failure to counsel the patients before and after the medication. And second is failure to screen for interactions and contraindications of drugs which the patients are receiving. Errors of commission. When we make a commission, when we miscalculate a dose of a drug, and when the dispensing the medication, we are incorrect in terms of dosage strength or dosage form. Nursing concern regarding errors in medication administrations. We have come to know when we categorize these administration errors, they are following under the 4 categories. First is the knowledge-based errors. If we are not having enough knowledge about the pharmacology of the drug, and that is why pharmacology in the second year BSc nursing is very, very important. Children normally try to avoid that, but it is the most important part for any nurse who wants to work in the hospital. Giving injection, example, giving injection penicillin without establishing whether the patient is allergic to the penicillin. Second is rule-based errors. Example, you are injecting diclofenac into the lateral thigh instead of the buttocks. Action-based errors. Example, picking up a bottle containing diazepam from the pharmacy shelf when intending to take one containing dilitizam. Memory-based errors, giving penicillin knowing that the patient is allergic, but forgetting that because of memory lapse, you have given the patient that injection. Types of one minute, please. Factors associated with healthcare professionals from the nurse's point of view, they are the types of medication errors. First are lack of therapeutic, that's fine because I couldn't see the screen. Types and cause of medication errors from nurse's viewpoint. Factors associated with healthcare professionals. Lack of therapeutic training, inadequate drug knowledge and experience, inadequate knowledge of the patient, inadequate perception of risk, overworked or fatigued healthcare professionals, physical and emotional health issues, poor communication between healthcare professionals and patients. These are certain factors which many of us have undergone during our service time, and students will find they can tick mark whatever they have felt, and these factors have to be removed if we need to do better. Factors associated with patients. Patient characteristics like patient's personality, literacy, language barriers, complexity of clinical cases which include multiple health conditions, polypharmacy and high-risk medicines. Factors associated with the work environment, a very important factor. When there's a lot of work and time pressure is there, distractions and interruptions by both primary care staff as well as the patients. There are lack of standardized protocols and procedures in many hospitals and many wards, and this could lead to serious problems in medication administration. Insufficient resources, lot of work, lot of patients, very few faculty, very few staff, very few nurses. We have so many millions and millions of nurses who are found less in this world today, and that have been highlighted during COVID 2019. Issues with physical work environment like lighting, temperature, ventilation. My dear friends, I would like to say that factors are also associated with medicines too. They are the naming of drugs, labeling and packaging. Factors are associated with the task. Repetitive systems for ordering, processing and authorization. Patient monitoring, dependent on practice, patient and other healthcare settings prescriber. Factors associated with computerized information systems, which is this is a computer technology. 21st century is a computer era, and the age of computer era. I take this particular moment to thank and congratulate Keshkali, Principal, Vikrant Institute of Nursing, for training me on how to come on webinar. And I'm extremely thankful because now I feel I've become modern as per 21st century in this particular state. Factors associated with computerized information systems. They are difficult processes for generating first prescriptions, difficult processes for generating correct repeat prescriptions, lack of accuracy of patient records, inadequate design that allows for human error, primary-secondary care interface, limited quality of communication with secondary care, little justification of secondary care recommendations. And there are special circumstances which are relevant to medication errors in primary healthcare settings. Patient safety is the ultimate goal that we need to come across. Patient safety is an emerging healthcare field and has directly or indirectly affected all the stakeholders in the healthcare delivery system. I quote Liam Donaldson's, "To err is human, to cover up is unforgivable. To fail to learn is just inexcusable." Therefore, we as nurses, if we want to prevent medication errors, we should know in detail what are the rights of patients. हमें patients के rights के बारे में जानना बहुत ही important है. And there are some 13-14 rights which I have just listed down, as you can see on the screen. I will just mention the three most important ones. Their right to appropriate medical care and human treatment. Each one of us have that right. A right to informed consent. Anything the doctor is doing, there is a need, and for us to know everything what the doctor is doing to the patient. A right to information. Right to information is very important because then only patient will cooperate in all the treatment activities. And there are so many rights to religious beliefs, medical records, leave, refuse participation in medical research, correspondence and receiving visitors, express grievances, and right to be informed of his rights and obligations as a patient. If we know their rights, we will start acting in a positive manner. Other problems that we come across are the drug nomenclature. You know, a drug can have several names. For example, some drugs are having even 4 names. A chemical name is any typical organic name, and this precisely describes the constituents of the drug. For example, N4-hydroxyphenyl acetamide for paracetamol. And the generic name for paracetamol is the name given by the manufacturer who first develops the drugs. It is given before the drug becomes official. Name is also approved by the WHO. And this name is often derived from its chemical name. For example, for paracetamol, the generic name is acetaminophen. So this is how we have to be knowledgeable about the pharmacology of drugs. Physician's order for medication. Every nurse working in the hospital, in the wards, my dear students, when you go and give bedside nursing, bedside administration of medication, please remember that every doctor's order should have these 7 essential parts. When they write the treatment, first of all, they should write the patient's full name, because there may be hundreds of people with the same name. There may be hundreds of people with the same surname. There may be, you have found in classes, in your own lecture classes, girls or students, boys, students having same names. 2-3 boys having same name. The teacher has to write boy number 1, number 2, number 3. We have to codify to remember which child it is, or to link with the parent's name. In the army, we have a unique ID, personal ID. We are designated by a personal number which is given to us, and because we may have many people with the same name, therefore the doctor should write in his prescription these 7 things are very important for you if you want to prevent yourself and prevent medication errors. Their patient's full name, the date and time when it was prescribed, what is the drug's name, the dosage, route of administration, time and frequency of administration, and the signature, which is a very essential part because they are authorized signatories of an order. Another important things which we nurses face and as students we need to know is LASA, that is look-alike and sound-alike medicines. LASA is look-alike and sound-alike medicines, which involve medications that are visually similar in physical appearance or packaging, and names of medications that have spelling similarities and or similar phonetics, or they sound alike. For the categories, spelling error, please mind the spelling error, sorry. Drugs similar brand names, drugs may be of similar brand name but different generic name. For example, there are two drugs. One is Losec, which is actually omeprazole, and Lasix, which is furosemide. Similar brand names and similar generic drugs also. They are cetralone and cetro, which is cetirizine hydrochloride. Similar brand names with an additional letter. Fevadol, Fevadol Plus, Fevadol Extra, Fevadol Cold and Flu. All sounding same. Now, what drug has to be given when? That you should know. And that is why you should know pharmacology. Similar brand names of the antibiotics group: Ciflox, ciprofloxacin, Moxiflox, moxifloxacin. Other categories are same drugs, different dosage forms. For example, Voltaren tablet. They are Voltaren tablets, there are supplements, there are suppositories, there are gels, there are eye drops, there are ampoules. Same drug, different release characteristics. They are released at different rates. Example, nifedipine, Adalat, retard, Adaleta. And same drug or generic name, different composition. Amphotericin B, Lsec, liposomal amphotericin B, ambisome. So we see so many confusing names. It's very difficult unless you are regular with your wards and your clinical duties and your pharmacology studies. The more you work, the more practice you gain, the more you learn, the more you remember. Generic drug spares, you see, they are having, the ending is same, but the front letters are different and have different functions. Vincristine, vinblastine, ephedrine, epinephrine, lorazepam, clonazepam. So these are the categories under LASA which we should remember. And confusions occur not only with us, it occurs for everybody who are in the healthcare team. For example, in prescribing by doctors sometimes, prescriptions can be wrong. Dispensing can be wrong by the pharmacist. Administration also can be wrong by the nurses. Therefore, knowledge update can only prevent you from making errors and keeping patients safe. Strategies to reduce these errors with LASA, they are at the procurement stage. Right from the beginning, when you're procuring, you should remember that you have procuring the correct item, the correct amount, the correct number, and the date of expiry should be there. The storage, use of tall man letters. Use of tall man letters, meaning that you have to put the storage section in the cupboard. You have to use the capital letters for certain drugs which you need to store so that you can identify immediately. The dispensing, prescribing, administration, monitoring, information, patient, all the strategies in each and every line you need to do, in every action you need to undertake so that you can avoid these errors. And especially when, if nurses are involved in indenting of a medication, indenting, writing down in the indent book, your handwriting should be good, they should be legible, the dose, the drug name should be spelled correctly, and the quantity asked also should be correct. You should not ask anything more than what is required because there can be misuse of drugs. You know, this pandemic COVID-19, we are all sitting inside the houses, but we have joined together. That's a great, great thing in the day today. However, there are medication errors which have been happening. And I happen to, because we can't take much time, but I would definitely like to tell you certain instances or whatever knowledge I have, information I have found out from the literature. Institute of Safe Medical Practice, ISMP, has received several COVID-19 related medication errors each week. And an investigation study using intravenous doses of remdesivir to treat patients with severe COVID-19. The adult protocol called for an initial loading of 200 milligram, that is stat you should give 200 milligram, followed by subsequent 100 milligram doses. Now what happened, you see? Each vial of remdesivir contains a total of 100 milligram. Instead of using one vial to prepare each 100 milligram subsequent dose, that means this is not the start dose, 2 vials were used. That means patient was administered 200 milligram for every subsequent dose. It was only the start dose instead of the intended 100 milligram dose. And this is where mistakes can occur. Doctors were understandably desperate to help their patients, but the resultant, it has been found in the early stage doctors who were desperate to help their patients, but there was so much of frantic panic, and there was resultant frantic prescribing, especially of hydroxychloroquine, and which probably caused more harm than good. We are all human beings, overstressed, overburdened, but we need to pause, think, and then take action where drugs are concerned. I just quote one example of a 40-year-old intubated COVID-19 man who received Verampil instead of Worst. Worst is a former brand of midazolam in the ICU. The patient had become agitated. So the physician asked verbally a nurse to increase the dose rate of the patient's propofol infusion and to administer Worst 2 milligram IV push. You know the reason why. But the nurse used the override feature. What she has done, she used in the automated dispensing cabinet. You know, there are cabinets which dispense automatically. She used the first 3 letters of the drug, and she's cabinet ADC to select and access the drug Worst by entering the first few letters of the drug name. The moment she did that, the wrong drug came out of the cabinet. And what she did was she accidentally selected and removed a vial of Verampil 5 milligram or 2 milligram from the ADC, which was available via override. The nurse administered Verampil IV push to the patient, believing it was Worst. She did not employ the available bedside barcode scanning system. We have a barcode scanning system also because the medication was a verbal order and had not been entered into the health record. What happened? After 15 minutes later, the nurse recognized the error when documenting. She remembered that when documenting, and the patient was monitored and suffered. Thank God he suffered no long harm from the error. And it has been noticed that 5 medication errors have happened during pandemic. One is hard to read remdesivir label. These are the errors. You know, the labeling is so fine and small letters, and in that hurry with all the PPE kit and your eyes with the chashma, it's difficult to read the small letters. So the dosages you can make mistakes. So exercise caution. Lack of staff training in using. Many of us do not know medicine barcodes and how it's used. When I got trained, it was not medicine barcodes were not there. But then because I am in the teaching profession, I keep myself updated. But still, I think the children today are much benefited with all these technology. Inability to weigh patients' accurate, correct dosage. There are patients of COVID-19 who are at home who are asking telephonically the doctor for the medications and the treatment help. But the doctors are finding it difficult because they have to give certain drugs related to how much of weight the patient is. To get the correct dosage, there also medication errors can happen. Automated cabinets also are dispensing the wrong drugs at times. They may be placed in the wrong manner. There are missed doses linked to rationing of personal protective equipment. Why mixed doses? Missed doses. Why? Because people, once they wear the PPE, they are in that PPE for long, many hours. And they have to give morning drug, afternoon drug, evening drug. And supposing they have not taken everything together and they have to go 2-3 times. So they try to avoid sometimes. And that is when it is missed. Or they give it little later or little early. That is wrong. Dear friends, my August gathering, let me tell you the legal aspects of medications, because I don't want any patient complaining of medication error harm. Neither I want my nursing colleagues or my health personnel, whoever is sitting in the conference, to ever face legal punishment because of wrong task. So we should know the acts. Dangerous Drug Act, which was instituted in 1930, and the Narcotic Drugs and Psychotropic Substance Act, which was in 1985. The acts govern the procurement and use of drugs, especially the narcotics. Narcotics cannot be bought without prescription, we all know. Dangerous drugs to be kept under lock and key and under the trusted senior nurses' command. Nurses are responsible for their own action. Mind you, don't think that if we make mistakes, somebody else will pay the price. You know, like that Vikas Dubey got caught. He killed 8 policemen and he got caught and he will pay his price. Everybody has to pay their price. So we better be alert and do right actions, right thing. I'm not comparing any one of us with Vikas Dubey, but we will become Vikas Dubey if we are making medication errors and we are putting patient into trouble and harm. So please be aware. Nurses are responsible for their own actions regardless of a presence of a doctor or a presence of a written order. If the nurse gives an overdose of a drug because it is written by a doctor, the error will be accounted to the nurse and not the doctor. Why? Because nurses also have pharmacology and they are supposed to read well, they are supposed to understand well, they are supposed to learn before they give it. It's a new thing. Nurses should remember always in their heart and mind that any drug, maybe a small tablet, they're all poisons. Why? Because we are not prescribing authorities. They are all poisons. If we start thinking like that, then we will be cautious of every action that we do. Therefore, and we must also remember that the right dose will differentiate a drug from a poison or a remedy. Between the two, the right dose only will be the one which differentiates. Therefore, nursing responsibilities are that nurses are actions, liable for their actions, omissions, commissions which they make. They are personally responsible legally, morally, ethically for every drug that they administer. Drugs can help or even harm the patients. Nurses, physicians, and clinical pharmacists are held legally responsible for safe and therapeutically effective drug administration, no matter who actually prescribed it. All members of the health team may be held liable for a single injury to a client. Therefore, we must remember always the 10 rights. In our days, we have learned about the 5 rights of the patients in medication administration. Today, it is added and we have to learn the 10 rights, because as more and more advancement takes place, more and more problems come up, more and more errors come up, and more legislations and rules are made. Follow proper medication reconciliation procedures, double check or triple check. Have someone else check. If you can't read properly, have someone else check. Have the physician, another nurse read it back. Consider a name alert. Put a 0. Putting a 0 in front of the decimal point is very, very important, even for the doctors as well as for the nurses who is entering in the treatment book or in the health record. Because when I write 0.25, it means 0.25 milligram. That means less than 1.0. And if I say 2.0 to 5.0, it means 25. That's the vast difference it makes. So that is why science and mathematics learning that we have studied in our school is very important. That 0, putting that 0. Today, if I tell you, I am giving you rupees 1,000, and while writing, I write 0001. How many rupees you'll get? You'll get only 1 rupee. But if I have to give you 1,000 rupees, I must write 1000, right? So that is the difference a 0 makes in the decimal point. Learn your institution's medication administration policies, regulations, and guidelines. Consider having a drug guide. The nurses who are students must always keep a pocket guide for drugs. We have the nurses' drug book, which we advise all students to buy and keep with them as a Bible when they go to the wards, so that if in case they have to refer, they have immediately the reference text with them. Others are obtain the current knowledge, refuse to administer. You have the power and the right to refuse to administer the drug if there is a reason to believe that it will be harmful to the patient. Unless you are properly explained the effects of that, performing correct techniques and precautions, monitoring client response and documenting drug effects, patient and family education. So the 10 rights are right drug, right patient, right dose, route, time frequency, documentation, history and assessment, drug approach, right to refuse, drug-drug interaction evaluation, right information. I know I'm taking a little longer time, but can't help it. टीचर है ना, तो इसीलिए बच्चे बैठे हैं मेरे सामने, बंद नहीं कर सकते हैं, 40 साल का तजुर्बा है, तो प्लीज माफ कीजिएगा 2-4 मिनट अगर ज्यादा ले लें. So administration errors account for 26 to 32% of total medication errors. I'll just tell for the senior nursing students who are sitting there, for anybody with research minded days, fourth year BSc nursing, MSc nursing students, the PhD nursing students, we always, when we do any presentations or when we quote some things, we must give a research findings. I tried to find some Indian researchers, but unfortunately I could not. So I one or two research points which I have identified, found, I'll just go through. M.A. Chiragi in 2013 in a cross-sectional study conducted in 2009 among 237 nurses, randomly selected from nurses working in the in Komini Hospital, it was found that medication errors was made by 64.55% of the nurses. Most common errors were using abbreviations instead of full names of drugs and similar names of drugs. And the conclusion drawn was the common cause was due to lack of pharmacological knowledge among the nurses. The second research done by S. Badi et al. In a study of medication error reporting rate and its barriers and facilitators among 733 nurses working in Urmia University of Medical Sciences, Iran, found that the rate of reporting of medication errors among nurses was far less than medication errors that they made. That means they have made mistakes, but they have not reported. And that is the case even in India. We have found some cases. Pardon? Important barriers, they are the concerns. These are the important barriers that we come across through the research findings, and they are the facilitators. Facilitators, when will the nurse report? When she feels the working environment is good, my seniors will understand my mistake, I'm only human, I will not be blamed or punished, but I will be guided and trained or whatever punishment in a lighter way. If they have good relationship, they are free to talk with their seniors. And if there are errors in the principles itself, these are the good professional relations with, then only they'll report. So I have got a lot of research articles, which I will skip through because of the time. But this is the error which have been found in computing an error, that administration, there were 58%, documentation, transcribing 22%, dispensing 17%, monitoring 1.5%, patient compliance 0%, prescribing 1.6%. So these are again the various type of medication incidences that are happening. Large variety of drugs in medicine cupboard, using acronyms, similar names, using other drugs in medicinal and different medicinal doses. Incidents, types of human and managerial which we can avoid. The nurse managers and in the hospital setup, the hospital administrators can also have a look at it. Too busy and tired from excessive work, few number of nurses compared to large number of patients, inadequate training of the staff, lack of pharmacological knowledge, incorrect medicinal calculations, illegible data card, illegible prescription. So practicing these things will only make us perfect. Another research done in 2000, this is the latest research in a study on medication error. Is it the hidden part of the submerged iceberg in our healthcare system, which is not seen, and it is found that the perception of nurses, it says that the causes, spelling error, CAU, cause of medication errors were including illegible physician handwriting. They are known for that. I do not know what is the reason, but out of 100 physicians, maybe they have lot pressed of lot of patients to see, writing fast. Finally, they scribble something which is very difficult. Being a nurse, I find it difficult sometimes to read even my own doctor's prescription. So I have to ask him verbally, and he looks at me with a strange glance. But anyway, I don't tell him anything, what to tell, because poor thing, they are burdened with so many things. Only 45.6% of the 983 nurses believe that all doctor errors are reported. Reasons for not reporting include fear of manager with two horns, big eyes, popping eyes, protruding teeth, will punish, will shoot. No, count. I'm also manager like that at times, but not for these reasons. Peer actions. Nursing research done in 2019. Again, it was a retrospective study of nurse staffing, and it is found that among the databases of one hospital containing 801 weekly staffing intervals and 31,080 patient observations, findings revealed that increasing the number of registered nurses hours and decreasing the or eliminating the licensed practice nurse hours can be a possible strategy to reduce medication errors. And these medication errors, don't feel guilty. We may not report, nurses may not report, doctors may not report, criminals may not tell, but there is a heart, there is a conscience, we all feel guilty. And for that, these are the problems which we face. Psychological trauma can be overwhelming to a nurse. First, nurses worry about the patient. Secondly, they feel upset, guilty, terrified about making the error. In addition, they experience loss of confidence in the clinical practice abilities. And finally, they feel anger at their own selves as well as the system if the system is at fault. Therefore, nurse administrators all over the country must aim towards improving the right work environment, patient-centered care, teamwork and collaboration, evidence-based practice. In evidence-based practice, we must have skill mix and number of nurses. They should be mixed, and there should be longer lengths of stay in the hospitals, and higher healthcare will increase the cost, therefore reduce the medication errors. And most important, we must induce a culture of safety in the hospital campus, among the teachers, among the students, and blame game should not be there. Implications for the nurse administrators and educators, that errors should never be viewed as failures that warrant blame. Training should focus on knowledge rather than only on rules. Improving the system rather than punishing the individual. Give corrective punishment. Give formative punishment. Initiating action even if the patient has been the victim of medication error without any injury or adverse events. Document medication errors and promote research mindedness. The cornerstones for ethical decision making by nurses. Each nurse needs to identify his or her concept of ethical and moral correctness and responsibility. Therefore, she must follow the 4 principles of malfeasance, that is, the duty to do no harm, beneficence, the duty to do good, client autonomy, truthful justice and fidelity, faithfulness to one's obligations, and integrity, being true to one's word. I therefore conclude, we often take things for granted that deserve most our gratitude. So please do not take any patient for granted, any action for granted, any human being for granted, but do every work with the same commitment and dedication that you did on day 1, and you will reach the ultimate goal. Therefore, nurses, save 1 life, you will be called a hero. Save 100 lives, you are a nurse. Thank you.
Thank you so much, ma'am, for your wonderful and enlightened talk.
Thank you.
Madam, now I request my audience, if you have any question related to this talk, you can put it on chat box. It was very useful and valuable talk, madam. You have enlightened all students and clinical nurses and all of us. Really, medication error though it is very simple terminology, but when it occurs, it creates lots of problem. And it can be avoided by our certain policies and procedures which we are following should be followed carefully, read physician's order carefully. So thank you so much, madam.
Well, thank you. Thank you for giving me this opportunity.
I think there is no question, madam. Students have not asked any questions. I invite my managing director, Mr. Nitin Singh Thomas, sir. Sir, please acknowledge the talk of madam. Are you here, sir?
Yes, ma'am. Yes, ma'am. Thank you, ma'am. First of all, I must say, the session which you took was very nice and very wonderful. The kind of information you gave to all of us was quite very informative. Now, I just wanted to put in something here. The demand for the nursing profession is definitely going to increase due to this pandemic. And I mean, the same way, when the demand increases, the chances of error will also increase simultaneously. So we, as in running an institute here, we have a major part to play in it, because I feel like giving the proper academic, knowledge to the students and the clinical practice, that is on our part actually. So we are doing we are giving our 100% best. We're giving our best to these students so that they are well equipped with all kind of knowledges and the skills that they require in order to treat the patient there. And we will be definitely doing the same. And thank you very much, ma'am, again for the session. Thank you.
Thank you so much, sir, for patient listening. Thank you.
Thank you so much, sir. Thank you, madam. Thank you so much once again.
Thank you.
And in next, I invite our respected Dr. Ashok Mewara, sir, to give overview on the topic. Over to you, sir.
Stop sharing.
Good morning, everyone. Can you all hear me?
Yes, sir.
Yes, sir.
Okay. Actually, speaking to such an eminent nursing people and being not a nurse, just being a clinician, it's very scary for me, because doctors make a lot of mistake and blame the nurses for it. So I am at the receiving end of all of you. But anyway, I will just talk. I will on some experience I have and the observations I have made. And I work for a hospital, and we were, we had the JCI, the Joint Commission International guidelines we were following, and it was accredited by JCI. So instead of like ma'am earlier was NABH accredited thing, so I look at some practical points and very practical tips I can give to the nursing people on the type of mistakes they make and what can go wrong and how to prevent it. First thing, as per JCI, we have what we call the International Patient Safety Goals. These are the 5 or 6 standards which are very, very critically important. And if you miss out on any of these standards, your hospital can lose this JCI accreditation. It's an American accreditation. First thing is like identifying the patient, It is always said that use 2 unique patient identifiers apart from the room number, the bed number of the patient. Never identify a patient by a room number or his bed number. Because often, when a patient is to be shifted or injection is to be given, the nurse tells the technician, "Arey bed number 16 ko injection laga do, ya uska blood le lo." Now this can lead to a very serious problem because it has happened in a hospital where a patient was to be taken for surgery, and what they did was that in the night the patient was getting light from the window, so he told the other patient, "Can we change beds?" So they both changed beds, in the night. And so in the morning, the patient was to be taken for surgery, and they just pulled the bed out with the wheels and they rolled him into the operation theater. And the patient was sleeping, So, and he was supposed to be sedated. So when they reached there, and he said, when the doctor asked him his name, we found that there was something discrepancy in the name. So we asked him that, "Are you here for appendix surgery?" He said, "No, I am here for a joint pain problem." So then we suddenly realized, that using a bed number could be very dangerous, or a room number. So always use two complete patient identifiers, maybe a patient's unique Indore number, his name, full name, and this thing, or you have those bands that you wear on the patients are given on Indore, those bar-coded bands and things like that. Please use two patient identifiers before you touch your patient or administer any sort of medication to them. Second thing is, what we called a telephonic order and a readback of the order. What happens is often in the night, the nursing staff rings up the consultant at his home and tells him my patient is having so and so problem. And the doctor gives, tells him you give, maybe suppose there is a pulmonary edema and he says, oh, well, you give an injection of Lasix. Now, the rule is that the nurse listens to the order, then she writes it down, the whole order, and then she reads back in a very detailed manner to the consultant that, sir, I understand that you have ordered injection Lasix, Lasix, which is to be administered 100 milligram intravenously at 2 o'clock or 3 o'clock. And he says, yes, I do confirm what you are telling me. And then she writes it down on the paper, and next day in the morning when the consultant visits the ward, he has to countersign the order he gave telephonically in the night. So this is a very important thing that you must practice, that you please read back to the consultant, giving the route, the administration, it is to be subcutaneous, it has to be given, whichever way. So that is very important. Another thing is what I have seen in my clinical practice is that when nurses write down orders, what they do is, suppose it is to be given, a dose is to be given TDS, then they will write 8-2-8, means 8 a.m. in the morning, 8 p.m. and 2 o'clock. Well, actually what happens, there are 15 patients and she starts administering at 8 o'clock the first patient. So by the time she goes to the 10th patient, it is already 9 o'clock, but she is administering at 9 o'clock, but entering data as having given at 8 o'clock. So this is a mistake, because the next nurse comes in the evening and starts administering from the other end onward, you will find that the gap has been reduced or increased by at least 1.5 hours to 1 hour. And that can cause serious problems where we have very dose sensitive, time sensitive and dose sensitive medications. So if you are administering at 8:20, please mention on the file that this patient was given at 8:20, not at 8 o'clock. Like you just tick off 8 o'clock dose. And so that has to be prevented. Something else, all high concentration electrolytes that you have should be kept in a separately locked almirah, and the authority to order and open those high concentration electrolytes should be given limited and given under very specific orders of the doctor. Like, so if you giving potassium chloride, if it comes to you instead, it looks like a glucose vial. So if you administer it, it can cause immediate death of the patient if you give KCl the way you administer glucose IV. So these certain things we have to be very, very careful about storage and dispensing of high concentration electrolytes. The third thing is the correct surgery that is to be conducted. So it's a responsibility in our hospital, in Reliance hospitals, it was a thing that the nurse, in consultation with the patient, even before he was taken for surgery, would draw a black mark. Suppose it was a right knee to be operated. She would tell the patient, listen, you and me, we understand that your right needs to be operated, right? They say, yes, yes. And she draws a big circle on the right knee before the patient is taken. Or he says appendix is the surgery. So she draws a circle upon the appendix area and makes a cross there. So even if there is a mistake, of the wrong patient going in, when the surgeon looks at it, he looks for those black ink marks that has been marked with the consultation of the patient by the staff nurse in the hospital. So we make sure that a wrong surgery and wrong patient do not land up in the hospital. Another very important thing is what I've noted is a lot of medicines patients keep in their bedside lockers. And what happens is that patient often, when the nurse is not there, they try and self-medicate. If we do not want to ring the bell at 2 o'clock in the night and the nurse will come and then she'll get angry and why you are this and what's the problem and the thing. So he has a mild headache. He opens a drawer and takes a self-medication. And often they land up taking the wrong medicine from that thing because they do not understand the look-alike and sound-alike principles of medicine. His own medicines kept there, he might, make a difference, mistake some painkiller with some other drug. And this sort of medication errors also we have noted where the patient self-medicates himself. So all bedside lockers should be locked and the key of that locker should be kept with the nurse who's in charge of that room or ward. And so she carries it in the tray with her when she comes to the patient. She opens that locker in front of the patient. She takes out the medications, administers it, and then puts the remaining medicines back and relocks the thing and keeps the key with her. The key of the patient's bedside locker should not be given to the patient because there is something known as drug automatism also. Sometimes what happens is they take a sleeping pill and they feel they're not feeling sleepy, so he takes another compost. And then it's still not feeling sleepy and there is something known as drug automatism which takes up. They don't go to sleep, but they keep feeling that they had not taken the medicine. So they keep taking multiple doses and they land up in poisoning. So that also to prevent that sort of a medication error, the bedside locker key of the patient should not be kept with the patient. Also, before when you admit a patient, please ask for previous medications or any other medication the patient is taking. Because a lot of time what happens is that these patients, they do not give credence or importance to a lot of other medicines they were taking at home. Or they even continue to take in the hospital, some Ayurvedic medicines, some homeopathic medicines. They think this is not part of your allopathy medicine. So they continue to self-administer all Ayurvedic and all other things which could be interacting with your drugs. So please look for a very detailed history of what medication the patient is currently taking. Often a lot of his routine medicines, like he's taking a thyroid medicine and he does not inform the doctor that he is on thyroid medication. And he forgets to take that. He says, no, I am in the hospital. So doctors knows everything. So they will give me a thyroid medicine. And he will, stop taking his thyroid medicine or any other medication. So these sort of things are also, we have seen very, very commonly happening in hospitals. And they can lead to serious faults, in the system. So these are the few things I think which are very important. And if you have any other questions, I can think. Because this is what I have noted as a clinician, and I am not a great teacher or a speaker, but I can just tell you from my practical experience and my GCI accreditation to the hospital, what these auditors were looking for and what are the faults they pointed out in our hospital and how we corrected them is just about all. Thank you very much. If there are any questions, I take them, please. Thank you.
Thank you so much, sir, for sharing your real life experiences about medication error. Definitely, it will be highly effective for audience and clinical nurses. Sir, many students wants to know that in your practice life, anytime you face the situation of medication error committed by nurses and remedies after that being occurred.
Oh, we face them all the time. Yes. And we have a system of reporting errors. And even you can report your own error that so-and-so patient was administered a wrong medicine and this is what happened, or it was a near-miss accident. And the hospital thing was that even if you have self-reported, we will not try and find out who the nurse made the mistake. What we do is we have a nursing council meeting which is attended by physicians, and these mistakes are shown that this mistake happened. who is the nurse, we are not going to point it to that, because that will stop nurses from reporting altogether. If we take them to this thing, we believe that this is a human issue, and the nurses are overburdened, they are stressed with their work, and such mistakes can happen. But recognizing these mistakes, looking at them in the meetings, and pointing them out that such a mistake has been made. We are not telling which nurse and which patient, but such a wrong administration of drug took place. Please be careful in future that we don't. Though as a top management, we knew who was the nurse, but we never put her name in that meeting before everyone else. We would just look at the problem and make sure that take everyone into discussion and ask them, how do you think we can prevent this from happening in future? So that was the approach we made, and it worked out very well, I think.
Yes, sir. Thank you, sir. Yeah, I can say to all the audience that if mistake occurs, if a medication error occurs, we should report it. Instead of hiding it, we should report it, because you have heard about sir's talk that it can be treated, it can be prevented, it can be managed. But if we are hiding, it can create consequences. So thank you, sir. Sir, as you know, to organize this national conference, our management was involved a lot. All the peoples of my higher management have supported me in all work of arrangement of this conference. So I request our treasurer of this society, Mrs. Garima Singh Tomar ma'am, to Madam put a remark on such talk. Madam Garima Singh Tomar. Garima ma'am, are you there, ma'am? Yes, madam is connecting, sir. Garima ma'am? Within a minute, madam will connect to us. She is connecting. Garima ma'am, hope you have joined us, madam. Yes. Madam, please acknowledge the talk of our Dr. Ashok Mewada, sir, madam. Garima ma'am.
Yeah. First of all, I just want to congratulate Keshkari ma'am for conducting such thoughtful workshop, or we can call it a seminar. And I was listening to all the speakers, although I was busy with something or other, I was occupied. I was just thinking that the topic is really good. So the topic is really good. Everyone is having a good knowledge. I just want to thank Ashok Mewada sir for being there with us, for being a eminent speaker of the forum. Thank you, sir, for being there with us. Thank you.
Thank you, ma'am. Thank you so much, ma'am. Sir, madam, everybody has supported me a lot to organize this. So once again, even I thanks to Madam Garima, ma'am. She was talking to me till last night, and she was asking about progress and all the arrangement. Madam, thank you so much for being so supportive. Thank you, sir. Now I invite our next speaker, Dr. Pramila R. Madam. Madam, please come on the forum and proceed with your topic, that is causes and types of medication error evidence-based. Dr. Pramila R. Ma'am. Madam, can you hear me? Madam. Madam is connecting. There is some issue and soon we'll start. Till the time Madam is connecting, I want to say my audience that please ask your questions and doubts if you have, because you have got a very eminent and learned speaker for the topic, and you can clarify your doubts, especially student nurses, MSc, BSc, and clinical nurses. If you have any doubt, any query, you can ask. Freely you can put this in chat box and we'll raise it. Abhishek ji, please unmute Pramila R. Madam. Abhishek Mishra ji, please unmute Dr. Pramila R. Madam. Sorry, madam. Sorry for inconvenience.
A very good morning to one and all.
Thank you, ma'am. Welcome you, ma'am.
Thank you, ma'am. First, let me give my bouquet of thanks to the management of Vikrant College of Nursing and Madam Keshkali Sharma for having invited me for this national virtual conference. And Madam, you actually deserve two more thanks. I would just like to brief you on that. One is, it is going well ahead of time. So I was just worried. You had given me the time of 12 to 1. Then I thought my children will be feeling hungry, how they would be able to listen to my talk. So that worry is off and I'm cool now.
Thank you, ma'am.
And the next one is, I think Dr. Kamlesh Singh and Dr. Ashok Mewara has done a little bit of my work also. But then I thought that the topic is going to be medication error, a little bit of reinforcement will be helpful for the students. So with this, I would like to start my session.
Yeah, ma'am.
The objectives of the session, it will go around like, first, they'll be able to define error and medication error, recognize the incidence of medication error, identify the factors that may influence medication error, list the causes of medication error, enumerate the causes of medication error, and appreciate various research evidences related to medication error. Since the topic is on evidence-based, the entire script is based on the research topics, right? To start with, I think Madam Kamlesh also has highlighted all that. So, yes. Errors are an integral part of human life. When we say errors are an integral part of human life, here, in this medication error, though there is a saying, error is human, to forgive is human, that cannot be applicable is medication error. Because we do not want such errors to happen, as already has been held that it is life-threatening when such errors happen. So what we require, ultimately what we require as nurses, passion towards the profession, whole lot of dedication and commitment. Many errors originate from the natural process of cognitive and behavioral adaptations, which develop the correct behavioral skills. Although medication errors...
Sorry to interrupt you, madam. I think there is some problem with connection. Your voice is not clearly audible. Yes, ma'am, you can start.
Can you hear me now, ma'am?
Yes, yes, it is very clear, ma'am.
Yes.
Thank you, ma'am.
Did you hear that, or you want me to start from the beginning? Hello, ma'am?
Yes, ma'am, yes, ma'am. Yes, yes.
Can you hear, ma'am?
Yes, ma'am. Clearly we can hear now.
All right.
Yeah.
So I was just telling that errors are an integral part of human life. So there is a saying in English that to err is human and to forgive is divine. So that could not be applied in medication error. That is because we are dealing with the lives of the human being. So we cannot take any little thing for granted here. So ultimately we require as nurses passion, dedication, and commitment. So many errors originate from the natural process of cognitive and behavioral adaptation, which develop the correct behavioral skills. Although medication errors can be caused by all members of health team, nursing medication errors are the most common because she is the one who is administrating the drug. The reason is that nurses execute the majority of medical orders and spend about 40% of their time in the hospital to administer medicines. And rates of nursing medication errors are high in developed and developing countries, as said by Jeragi. So what's an error? An error is something incorrectly done through ignorance or inadvertence. A mistake, example in calculation, judgment, speech, writing, action, etc., or failure of a complete plan as intended. Or the use of an incorrect plan of action to achieve a given action. So what is medication error? Medication error can be defined as a failure in the treatment process that leads to or has the potential to lead to harm the patient treatment process and that involves a medication. And I just brought a few medication error as stated by various researchers. Banning said a medication error is any preventable event that cause or lead to inappropriate medication use or patient harm. Nucleus et al. 2007 stated, medication error is a global issue where 5% of the medication errors are deadly and almost 50% are preventable. Brian et al. 2007 stated, medication error is one of the major issues in today's healthcare, and prevention is linked to accurate reporting of errors. So the first picture has told about accurate reporting of errors and its importance. So since my topic is about types and causes, so I thought I'll just focus only on my topic. So we have a little bigger definition that's given by WHO. Let's see what is it. The United States National Coordinating Council for Medication Error Reporting and Prevention defines medication error as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. Such events may be related to professional practice, healthcare products, procedure, and systems, including prescribing, order communication, product labeling, packaging, and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. So you're not worried that it's too long, so you're not able to grasp. So we're going to see all these things in the process as well as types. So you all will be able to get. So let's see the incidence of medication error. I've taken from few studies. Studies show the range of rate of serious patient injuries that is caused by the medication error as to 1.2% as given by Medicare et al. 2004, 9 to 13% by Anselmi 2007, 29% by Donchin et al. 2003, and 51.8% by Aguilar 2012. And it is estimated that 3.5% deaths per year in a survey in USA were attributable to medication errors as drawn by House C et al. 2014. A study conducted in southern Iran with the purpose of determining the frequency of medication errors, an emergency department of a teaching hospital revealed that 96.5% of patients had experienced at least one medication error, making the rate of errors 3.5 per patient. Given by Wazan et al. 2014. A United Kingdom study found that 12% of all primary care patients may be affected by prescribing or monitoring error over the course of a year, increasing to 38% in those 75 years and older, 30% in patients receiving 5 or more drugs during the 12-month period. Overall, 5% of prescriptions had prescribing errors by Every et al. 2012. And a Swedish study found that medication error rate of 42%. However, 2/3 were related to the failure to state the purpose of the treatment on prescriptions, and only 1% of errors resulted in an incorrect dose, given by Clayson et al. 1995. And a study from Saudi Arabia reported that just under 1/5 of the primary care prescriptions contain errors, but only a small minority were considered serious, given by Koja et al. 2011. Another study in Mexico observed that 58% of the prescriptions contain errors, with dosage regimen accounting for most cases, 27.6%, given by Zavaleta et al. 2008. Now that we have seen the incidents, now we'll see what are the circumstances the medication error causes, as given by Oshikoya et al. 2013. So she mentioned there could be 6 circumstances. One is choosing a medicine, writing a prescription, manufacturing the formulation to be based, in dispensing the formulation, administering or taking the drug, or in monitoring therapy. In choosing the medicine, it could be irrational, inappropriate, or ineffective prescribing, whether they are under prescribing, omitting something, or over prescribing, adding something which is not required. Or while writing the prescription errors include illegibility. Prescription errors include illegibility. So I think Madam has already said about not writing clear prescriptions. Managing the formulation to be used, wrong strength. A wrong formulation or a wrong label. In administering or taking the drug, wrong dose, wrong route, wrong frequency, and wrong duration. And monitoring the therapy, failing to alter therapy when required, erroneous alteration. With this, we just see what are the factors affecting medication error reporting, as given by the studies conducted by Australia and Jordan by Jamba et al. In 2018. So the proportion of medication error reporting among nurses could occur based on 3 factors. One is attitude. Incident reports do not present insignificant changes. It means the author meant the nurses take it into granted that by incidentally reporting that medication error has taken place, it is not going to result in any significant changes, so let us not report. So that kind which is organizational factor. It could be fear of disciplinary action. The nurse may think, if I'm going to tell, that's what I said at the beginning. If you're going to be honest here, so we are not going to award them. So definitely we are going to punish them. That would be, it depends upon the protocols of the hospital. Like Dr. Ashok said that he's not bringing the names of the nurses. That's too nice of them. But I do not know about the punishments or disciplinary action that varies from institution to institution. Not knowing who is responsible for reporting a medication error. After they have done, they do not know to whom they have to do. A lack of readily available medication error. A social factor could be a fear of losing respect of co-workers. If I'm going to say that I have committed a mistake, the respect what they had for us, whether it will go down. The next is fear of being blamed. See, a normal human tendency is that we can do mistakes, but we do not like to be blamed. With this, we go to what are the factors affecting medication errors. So there are a lot of studies which has given factors affecting medication errors. So I've taken only 2 of them. Remaining all studies stated the same. So I blended this 2 studies factors into one. And I've just categorized as 4 factors. 1 is human factor, 2 environmental factor, 3 managerial factor, 4 medical factor. Human factor. When we say human, who is administering is nurse, so it's nurse related. The first reason, the topmost reason what they're given is fatigue related from hard work. Number 2, insufficient time for drug administration. Third, psychological problems of the nurses, mood changes, insufficient pharmacological knowledge. I think the first speaker as well as the second speaker has told. It's not that the doctors will be writing the prescription and we have to see that and then give it. That is taking out the orders. No. It's a responsibility to know what the diagnosis of the patient is a drug, what is being given, whether it is for the treatment of that particular drug and for removal of what symptoms the drug is being given. So directly we are supposed to know that. At least what I felt that when we say that they are taking particular drugs for some minor ailments. Sometimes when we ask, they do not know what's the action of that drug. At least we are supposed to have the right to know what is the action of the drug which we are taking. So like that, it's possible for us to develop pharmacological knowledge. And Madam Musa has rightly pointed out that we do have pharmacology in all the nursing programs, with GNM as well as BSc2. Incorrect medicine calculation. See, probably you may think that all the nurses have come taking the science as a group and not maths. True. But we can use calculators if you think we are poor in calculating. But we cannot afford to make any errors. Inadequate attention should be the whole of cause for all the errors to be taken. Inadequate attention. Whatever the other reasons what is being given here are only the excuses for the nurses to commit error. So no assessment before administration of the drug, inadequate experiences, personal and family problems, no interest for job, financial or economic problems. All these are personal, but when we are emotionally intelligent and bring all that to our workplace, errors could happen. And number 2 is environmental factors. Heavy workload in the ward. A large number of critically ill patients. So we have to do more number of hours have to be devoted for that particular patients. A noisy environment can lead to some distractions. Overloading of treatment room or a small treatment room. A type of unit, say it could be a surgical unit, pediatric unit or ICU. Patients, family members. Sometimes the family members, when they are allowed to be there, they keep on asking you and nagging you. And that again causes distraction to the nurses. Lack of required equipment to administer particular dose, drug arrangement in shelves, arrangement of equipment in treatment room, inadequate lighting where you're not able to see a particular drug. Third is managerial factors, high patient-nurse ratio. The same thing it was given the other two as a heavy workload. It's the same thing reflecting high patient-nurse ratio, eligibility of drug orders in patient record. So this was also well stated by previous 2 speakers. When it is not, see, not necessarily the handwriting should be beautiful, but it has to be neat. So that a person should be able to read that, especially the drugs. Eligibility of drug orders in the cardex. Incorrect transfer of medication from medication order the patient's file to the cardex. when nurses are updating in the computer system, or incorrect transfer of medication order from the cardex to the medicine pad, or inadequate training of staff, the leadership style in the ward. The medical factors. It could be because of similarity in the form of drugs, similarity in the names of drugs, large variety of drugs the medicine cabinet, or using acronyms of names, different medicinal dosages, using some drugs in rare cases. I think the first speaker has already brought this. This is actually the classification that is given by the WHO. Then I thought I would just bring the factors exactly as it is. So you know how the factors would be listed in this slide also. So I just go through a little fast because already you have heard this. Factors associated with healthcare professionals, it could be lack of therapeutic training, inadequate drug knowledge and experience, inadequate knowledge of the patient, inadequate perception of risk, overworked or fatigued healthcare professionals, physical and emotional health issues, poor communication between healthcare professionals with patients. Factors associated with patients could be patient characteristics, complexity of clinical case, including multiple health conditions, polypharmacy, and high-risk medications. Factors associated with medicines could be making the medicines, labeling, and packaging. Factors associated with work environment, workload and time pressures, distractions and interruptions, lack of standardized protocols and procedures, insufficient resources, issues with the physical environment. Factors associated with tasks could be the repetitive system of ordering, processing, and organization, patient monitoring. Primary, secondary care interface could be limited quality communication, secondary care, justification of secondary care recommendations. Factors associated with computerized information system, difficult process for generating first prescriptions, difficult process for generating repeat prescriptions, lack of accuracy of patient records, inadequate design that allows for preventive. With this, let's see the causes of medication error. The causes of medication error as drawn by Anne and Mayo in 2003. In her study, she has ranked the causes of errors. So there she has one of 10 errors, and she has ranked, and it is being listed here according to the top. The first cause of error that is evident was physicians writing on the doctor's order form. It is difficult to read or illegible. Number two, nurses are distracted by other patients, workers, or events on the unit. 3, nurses are tired and exhausted. 4, there is a confusion between 2 drugs with similar names. 5, nurse miscalculates the dose. 6, physician prescribes the wrong dose. 7, nurse fails to check the patient's name bank with the medication administration record. 8, nurse sets up or adds an infusion device incorrectly. 9, medication labels of packaging are of poor quality or damaged. And the last one is, nurses are confused by different types and functions of infusion devices. So with this, let's see the categories of medication error classification as given by National Coordinating Council for Medical Error Reporting and Prevention. So the categories go from A to I. Category A says no error classified to cause error. B, error has occurred but it did not reach the patient. Category C says error that reached the patient. Error has occurred, it's reached the patient, but it's unlikely to cause the harm. Say multivitamin was not ordered on admission. Category D, error has occurred and it has reached the patient and could have necessitated monitoring and intervention to preclude harm. Regular release of metoprolol was ordered for patient instead of extended release. So there is a difference between extended release of that particular drug as well as regular release of that. Category E, error could have caused temporary harm, like blood pressure medication was inadvertently omitted from the others. So if it can be omitted, definitely you can have the patients can have an episode of high blood pressure there. Category F, error that have occurred and it could have caused temporary harm requiring initial or prolonged hospitalization, like warfarin, which which is ordered daily when the patient takes it every alternate day. So it means the patient can have more of bleeding tendencies. Category G, error that could have resulted in permanent harm. That means error has happened, it has reached the patient, and it has caused permanent harm. Example, immunosuppressant medication was unintentionally ordered at 1/4 the dose. And category H, error that necessitated intervention to sustain life. So here, category H, error has occurred, it has reached the patient, and it has necessitated intervention to sustain life. Say, for example, its anticonvulsant therapy was inadvertently omitted. So the patient was not getting the drug. There is a chance for the patient to develop convulsions there. Category I, error that could have resulted in death. Error has occurred, it has reached the patient, and it has resulted in death, like beta blockers not reordered post-operatively. So the studies say that.
Excuse me, madam. Excuse me, ma'am. Again,
Yes.
your voice is less audible, madam. Please make correction in your connection.
Yes, ma'am. Just give me 1 minute. I'll just get it corrected.
Yeah, sure, ma'am. Sure.
Am I audible now, ma'am?
Yes, yes, ma'am. Yes.
Sorry for the technical issues.
No, no. Yes,
So
ma'am.
with this, we just see types of medication errors. The types of medication errors as given by Isa Zay et al. In 2018, Bangalore. So in that study, they just listed 4 types of medication error. The highest percentage was found in prescribing errors, 2.33, and in administration, 41.66. Am I audible?
In between, you get disconnected, madam. So voice is not.
No, I can also see here. I can see that your connection is unstable. That's why I asked.
Yeah,
you.
it is unstable. I think connection. It is because of connection, madam.
Yes, yes. Now can you hear me, ma'am?
Yes, ma'am. Now it is very clear.
Okay, fine. So the highest percentage was for prescribing errors, 52.33, administration errors, 41.66, and the monitoring and dispensing, it did happen, but the percentage was less, 4.66 and 1.33 respectively. And the types of prescribing errors, what was the study, what they found is, one is incomplete prescription. That could happen because of missing essential information about the dose, route, or frequency, and that was the highest, 55.4%. Number 2, writing illegibly. So that's what we said, with the orders were not written neatly, or they are able to read it. Errors could happen, 21.65. Drug-to-drug interaction. For example, cyclosporin and ketoconazole, where it is given together, it can cause cyclosporin toxicity. Or amlodipine and haloperidol, when it is given together, it can cause arrhythmias. The fourth is incorrect dose. Like for meningitis, instead of ordering ceftriaxone 500 mg IV correct dose, they just ordered 250 mg IV BD was prescribed. Contraindicated. Like drugs have been administered in end-stage renal failure, prescribing 2 drugs at the same time, or lack of instruction of nurse, wrong dosage form, giving syrup instead of suspension, or a wrong drug itself. types of administration errors. So it could be because of documentation. So what's happening with documentation is that maybe the nurse have done it honestly. She has administered the medication, but she did not document it. The second nurse comes there, sees that documentation, and she will administer one more time again. Omission error by not giving wrong time or wrong dose, wrong rate of infusion, wrong drug, wrong technique, or the wrong route, wrong dosage form, or wrong duration. So these are the types of administration errors and the percentage which you would see there on the screen. And we just for Furner Ari et al. In 2006, I think Matt also has specified about these 4 types of medication error. So when actions are intended but is not performed, 2 actions could happen. One is mistakes from planning action or skill-based error. When we are doing the action, it could lead to that knowledge-based error as well as rule-based error. And skill-based, it could be action-based error or memory-based error. Route-based error, good rules not applied or misapplied. What could be a bad rule? Action-based error could be a technical error. Let's see each of the examples. Knowledge-based error, it could happen through lack of knowledge, like giving a penicillin without having established the patient is allergic. Or a rule-based error, using a bad rule or misapply a good rule. Example, injecting diclofenac into lateral thigh rather than butt. Third, action-based error. The slips. Example, picking up from a bottle containing diazepam from pharmacy shelf, intending to take diltiazem. Or memory-based error called lapses. Example, giving penicillin knowing that the patient is allergic and not forgetting. So, by forgetting. Now we see professionals involved and perceived cause of medication error. So you must be knowing that. Sorry to interrupt, ma'am. Ma'am, in case if my voice is not audible, please let me know. I'll continue the.
It is audible, madam. In between, I think it is fluctuating. Connection is fluctuating. So in between, it is interrupting.
We see the professionals involved and perceived causes of medication error.
Yeah, very nice.
As given by Krishna et al. 2015. So we know most of the who are the professionals that's involved in medication error are primarily nurses, pharmacists, and the physicians. So the majority, if you look at the percentage also, it is in that order only. So nurses, we could see that 67.4, and by pharmacists 22.1, and by physician it is 10.5. So what are the causes for each of them? Let's see. Untrained nursing staff, 19%. High activity duty hours, 39.6%. And repeated distraction, that 41.4%. And by pharmacists, it could be because of illegible handwriting, 42.1%, high workload, 10.5%, generic drugs, 26.3%, and repeated distraction, 21.1%. And medical error by physician, it could be because of workloads, 66.7%, and it's because of unclear medication orders, 33.3%. So with this, I'd like to add some more supporting studies to my topic there. A study that's done by Garcia et al. 2019, Spain, will identify medication errors and drug knowledge gaps at critical care nurses in ICU. It is done with the mixed method, right? So it was found that 1.3% contributed to potential prescription transcription errors, 8.15% to antibiotic therapy, medication 2.94%, and medication administered to nasal was 11.1%. And the same study said the main drug knowledge gaps identified among nursing professionals. What were they? They were in preparation or the administration of insulin, 92.5%, NGT administration, that's salicylic acid, that's aspirin which we give, 72.5%, administration of low molecular weight heparin, 60%, diffusion mixing in adrenaline, 60%, and either in dose or concentration or in infusion speed of the potassium chloride, 50% was found. And the second study with the young Hug et al. 2014 in Iran, the title Types and Cause of Medication Error in Nursing Students had done a descriptive analytical study among 62 final year students. The results show medication error was infusion rate, either they have done it more or they have already been very less. And the causes of medication error elicited in that study was in drug calculation. The errors that was made in drug calculation was 77.4%, and lack of pharmacological knowledge, which we are seeing right from the beginning. So the students also had same thing, 75.8%, and illegibility of patient's record, 72.6%. The third study says Mohanty S. 2016, which is done in Odisha, awareness of medication error, medication management and prevention among staff nurses. So I've just taken only medication error. A descriptive survey which is done on 100 staff nurses states majority 39% was not reading the instruction carefully. 26% of them claimed heavy workload. And 22% of them stated it's because of insufficient work experience. And there were others, one or two miscellaneous, they have included in 13%. Next study says, done by Mahesh M. et al. 2016 in Bangalore. Nursing perceptions of medication, of administration practices, reasons for errors and reporting errors. A descriptive survey done among 199 nurses said that this is about frequency of reporting errors. 66% of them reported always, and 18% of them said that frequently they used to report. And 3% of them stated half of the time they used to report. And 10% of them said rarely they report. And 3% of them said they do not report at all. The last study, Karthikeyan M. et al. In 2015 Kerala, done a systematic review on medication error among 44 studies, where it said highly reported prescribers error in the literature that was found was the highest was for drug-to-drug interaction, 68.2%, and for incomplete prescription, 25%, incorrect drug, 13%, monitoring and underdose, it was 12.6%, in incorrect interval, it was 12.1%. And the same study, he said also, highly reported nursing errors in the literature, which was found was for wrong rate, 34%, wrong time administration, 28.6%, wrong dose, 25.3%, medication omitted, 24%, wrong fluid, 22.4%, wrong drug, 21.2%, wrong route, 19.9%, and wrong patient, 19.7%. So with this, I would like to conclude. Once error has occurred, it is an ethical duty to maximize the benefits of patient care. It can thus improve patient safety and health. Therefore, managers should have a positive attitude toward reporting medication error. They should in fact consider error reporting as an opportunity to understand the causes of errors, and they will consequently be able to analyze cause and effect relations to establish better policies to prevent errors. And regarding the prevention and the safety errors, the next speakers will be able to highlight to you all and throw more light on that. With this, thank you. If you have any questions, please, you may ask.
Thank you so much, ma'am. Before I raise the question, I would like to say, madam, that really you have presented significant studies related to nursing practices, and this is alarming situation for the nursing practitioners to have proper training, proper knowledge, and proper practices. And it is very, very important, as your studies tells that improper knowledge is a significant cause of medication error. So it is responsibility of our nursing organizations too to give proper training to our student nurses so they can practice it with judicially in clinical setting. Any question? Students wants to know, madam, in case of emergency arrives in the hospital, what are the precautions to be taken? Because that time, sometimes doctors are not there, and emergency situation, they have to handle the casualties. That time, how they can manage it? Madam, please unmute yourself, madam. Yeah.
Can you hear me?
Yes, yes.
Ma'am, you just asked emergency situation. The question is, in an emergency situation when doctors are not there, what we could do?
Yeah.
So in India, we do not have a Nurse Practice Act. So far, we do not have. Legally, it is not what we are. What is our domain is only administration of drugs.
Yeah.
So once we are going to take, we are going to trouble ourselves. So that is why one error which we have found with physician is, so in that emergency situation, when we happen to contact them, they would give us a verbal order. And now that this technology has grown, and you said in this pandemic, we are able to make this national conference through this technology, nursing informatics have been come there.
Yeah.
So it is possible for the doctors to see from the place where they are. Not necessary they should be able to come, I'm going to say in an emergency. By the time he could travel and come through that technology, he'll be able to see what's happening, and he'll be able to do that. So as long as we do not have such legal acts, and if I'm going to advise you on that, then it means that I'm committing an error. So we always need to, for any kind of practice, even for as a nurse that we have to practice, we are supposed to have a registered nurse license.
Yeah.
So in countries, we can just see where nurses are there. Here in India, we have RN and RM. Whereas in few countries, if you happen to see, only RN is given, where they cannot work in midwifery area. So they have to have that license. So for us, unless we are going to have that license, let us not look for that. Let's remain only on nursing domain, and a lot of things which we can do. So that we need to rectify, and that we have to do.
Thank you so much, ma'am. Hope students have satisfied themselves by the answer given by madam. Thank you so much, madam. And I request our secretary of our institution, Mr. Vikrant Indore, sir. Sir, please acknowledge the talk of madam and give thanks. Vikrant Indore.
Good afternoon, everyone. I hope all of you are in great health and doing well. First of all, I'd like to thank Dr. Pramila R. Ma'am for sparing her valuable time and coming on this platform to address us with her vast knowledge and experience. I think these are the times to learn and to gain knowledge in your subjects. These lockdowns are hard on us, and I think this is a very nice way to utilize these times. And whatever knowledge you gain, and it's always beneficial. And someone who's willing to share the knowledge deserves a lot of praise and a lot of credit. So thank you so much, ma'am. I'm sure the session would have been a lot of, a very benefit to all the students and faculties. And last but not the least, I'd like to thank Keshkali ma'am for organizing the national conference and bringing such dignitaries from the medical and nursing fraternity on the single platform. Thank you so much, ma'am. Thank you so much, ma'am, for being here. Thank you.
Thank you, sir. Thank you, sir. Thank you, ma'am, Pramila. And sir is connected from Gwalior. Actually, our secretary, sir, is residing there and he's from there. So thank you, sir. Thank you, ma'am, for sharing your valuable knowledge. And now, this time, I invite my next speaker, Dr. Sadhana Upen Adhyapak, to discuss about working to reduce medication error and what to do if medication error occurs. Dr. Sadhana A. Adhyapak, over to you, madam.
Yes, thank you. Am I audible now?
Yeah, yes, ma'am.
Okay, sure. Thank you. First of all, I would like to congratulate Vikrant Institute and Professor Keshkali Sharma for this well-organized virtual conference. And to begin my talk, I would like to quote the words by Swami Vivekananda. He says, in all our actions, errors and mistakes are our only teachers. The one who commits mistakes, the path of truth is attainable by him only. But of course, it doesn't mean that we should commit mistakes or errors willingly. Because we, being the nurses, we are playing with the human being's life. Every day, we are in various clinical situations. And there are very high chances that we do certain mistakes. So one of the area where we can do mistakes is medication error. So today's my topic for discussion is reducing medication errors and what do you do if at all medication error occurs. Madam Pramila has highlighted on causes of errors. So I'll be discussing how these medication errors can be reduced. So what are the medications? The other name we call it as drugs. So these drugs are defined as they are substances intended for the use in the diagnosis, cure, mitigation. That means when you want to reduce the severity of something, of the disease process. So in that case also these substances are used. They can be used to treat or to prevent the disease. Basically, they are substances which is something else from the food. They are not food, they are other than food, which are intended to affect the structure or any function of the body. Now coming to the medication error, how do you define it? It is any preventable event that may cause or lead to an inappropriate medication use or patient harm while the medication is in control of the healthcare professional. So any healthcare setting, it can occur in all settings, it can occur at home also. If patient is not well educated how he or she has to take the medication, so there are in home also there are chances, in community, and of course in hospital settings. So any settings medication error can occur. It may or it may not cause adverse event. Every time, not necessary that it will cause adverse event, but still the reporting is important. The medication error should be reported. Now, when there is increased risk, when and which are the areas where there is increased risk of medication error? So when you want to give medications with complex dosing regimen, so I'll tell you one example. If you have 1 milligram of medication in 1 ml of ampule, and you want to give 300 microgram of medication, the available dose is 1 milligram in 1 ml and the order dose is 300 microgram. So in that case, it becomes little complicated. So there is a risk that you make a mistake. There are high chances that you make a mistake while giving medication error. Second, when the patient is on multiple medications, there are many drugs ordered. Some are once in a day, some are at the night time, some are 3 times in a day. So there are chances that you make a mistake. Third thing is when many physicians or doctors are involved in treating the patient. And of course, babies and children, because adults, they may are aware of their doses, their timings, but children, they don't know. Whatever we give, they just take it. So these are the cases where there is increased risk. And specialty areas like intensive care units, emergency departments, diagnostic or interventional areas, these are the areas where along with routine medications, some other specific drugs are used. So maybe there is a chance that the healthcare professionals, involved healthcare professionals, they are not very much exposed or used to give those extra drugs. So that is the reason why there is increased risk of medication error. Now coming to the point, reducing medication errors. Now, during ordering, only authorized person will prescribe the medicine. So usually in our setup, the clinicians or the treating doctor, they are responsible and they will prescribe the medicines. If at all, if junior doctor is prescribing medication, it should be countersigned by the consultant or the treating doctor. So pharmacy, it is they should see that the counter signature is there. Prescription which is not on the hospital letterhead, that will not be accepted by the pharmacy. Usually in most of the hospitals or where accreditation policies are available, all those big hospitals, they have a policy that the medication is written, the prescribed by the authorized person, and the indent is sent to the pharmacy. So the indent which is not on the prescription, the letterhead, hospital letterhead, will not be accepted by the pharmacy. Then only registered nurse should give the medication. In case of any doubt, should be cross verified. Then in case of telephonic of oral instructions, same shall be noted in the prescription by staff nurse, and counter signature should be obtained. It should be obtained as soon as possible, or at least within 24 hours, because sometimes you cannot take the risk of the patient's lives. So in that case, when you don't have time, the telephonic or oral instructions are acceptable, but it should be noted down immediately as early as possible. And in that case, you can follow the read back policy. That is, whatever is ordered, you just repeat it. You repeat the name of the drug, repeat the dose, repeat the route, and just to make sure that the same is ordered. So this is the way, this is one way where you can reduce the medication errors. Second is regarding storing. All the drugs should be stored as per the storage requirement. So one should be aware how the drugs are stored. Most of the time, on the labels, the instructions are written at what temperature the drug should be stored. Certain drugs are stored at the lower temperature. So the health professional should know that they are supposed to be kept in the refrigerator. Certain drugs, they are not supposed to be getting exposed to light. So all those instructions should be followed while storing the drugs. Then one more thing is that one can always store the drugs in alphabetical orders of their usually generic names are followed. If at all, if there is any confusion, in that case, brand name can be followed. But most of the time, alphabetical order in of generic names is followed. The area where you store the drug should be clean and well. The adequate lighting should be there, because in case of emergency or where you in a where when you are in a hurry, you can clearly see the labels if adequate lighting is there, and you don't make any mistake while selecting or taking the drugs. That is why lighting is important. Then one should follow the inventory practices. Most of the hospitals, whatever 2 shifts or 3 shifts, or every shift, the staff nurses, they check the inventory, and they sign it, check the number of drugs, number of vials, ampules, and so this inventory practices should be followed. Then emergency medicine shall be available at all the time. Usually medicine areas like intensive care units, the emergency medicines are kept in the crash cart. So if in case they are used during emergency, whatever vials or ampules are used, they should be replaced from your extra stock immediately. And later on, you can order for your extra stock. But emergency should be available every time. Then next, cytotoxic drugs, usually they are not stored. They are brought only once they are ordered or once there is a prescription. Then when you have a sound like or look like medications, they are stored separately. One way to store those drugs is tall man lettering. For example, you have the drugs like metformin or metoprolol. So that met is written in a common format, that formin and aprolol, that can be written in capital letters, so that it makes, so that you're sure with the names of the drugs, and then you don't make any mistakes while taking the drug. Then the person who is checking the inventory can always check the temperature of the refrigerator. Then medication should be protected from the loss. If you check the inventory regularly, naturally the loss is avoided. And regular audit, most of the hospitals, they do regular audit every 3 to 4 months. Audit is done. So this is regarding the storage and how you reduce the medication errors. Next is about the prescription of medications. The authority to order medications is limited only to registered physician, and only standard prescription format is used to order medication with there are certain things which are very compulsory to write in the prescription. So few things I have mentioned here, that is name of the patient, IPD number, date of prescription. If it is a pediatric patient, specifically the age and weight of the child should be mentioned because the doses vary, they differ. Then the generic main name of the medicine can be written. The dose, route, strength is mentioned, and prescriber's name and signature should be there. If all these things are then it, in that case only it becomes a complete prescription. Continuing with that, the separate prescription should be there for each and every patient. Consider individual patient factors like pregnancy, lactation, comorbidities, and other medications, because certain drugs like antihypertensive drugs, ACE inhibitors, angiotensin converting enzyme drugs, they are used very cautiously or not used during the pregnancy, because if they're used, there can be ill effects on the fetus. So some drugs are transmitted through the breast milk or through the placental barrier. So the person who is ordering the medicines, he should be aware of all these drugs. Comorbidities like liver diseases or kidney diseases. So in that case, liver won't be able to metabolize the drugs, or if kidneys are not functioning, the kidneys won't be able to excrete the drugs. So the person who is prescribing drugs should be aware of all these factors like pregnancy, lactation, comorbidities, and the other medications on which patient is already on. Then names of the medicine should be written in prescription as well as the doctor's order sheet. Now, in some hospitals, what happens? There is a separate column for stat orders and regular medicines. One example I will give you. Once there was a stat order for injection tramadol, but the order was not written in stat column. It was written in regular sheet. So continuously the medicine was given, and after 3 days, it was found out that actually the order was only stat. So the person who is writing and the person who is giving the medication should check exactly. So that is why the names of the medicine should be written in prescription as well as the doctor's order sheet correctly. Then check whether name, dose, time, frequency, route of drug administration is written in the prescription. Only name is not enough. Along with that, dose, timing, route, frequency is also important. Then verbal orders are followed only if delay in the writing orders will compromise the patient. As far as possible, the verbal order should be avoided, but in case of compromising patient care, in that case it should be followed. But as I said previously, it should be get written immediately as early as possible. Then as far as possible, the abbreviation should be avoided, but sometimes the standard abbreviations can be used if it is a printed electronic thing you're using, or the at least the handwriting should be legible, because sometimes you write injection IN or IM, so there can be confusion with N and M. The nasal can be read as intramuscular, so that should be very legible handwriting. Then when QD, actually QD is every day, but the person can interpret as QID, which is actually 4 times a day. So as far as possible, abbreviations are avoided, or only standard abbreviations in clear handwriting can be used. Now, if there is a doubt regarding prescription, that is illegible handwriting, if you think that the strength of the medicine is wrong, then similar sounding medicines, in that case, nurse should get it corrected without causing any convenience to the patient. Now, in this case also, I'll give you one example. Actually, the order was written Carden 30 milligram was order, actually, which is supposed to be antihypertensive drug, but it was read as codeine 30 milligram. And when the history was checked, that particular staff knew that patient is a case of migraine headache. And then she thought that maybe it is given as an analgesic for headache. And then instead of this antihypertensive drug, this codeine was given as an analgesic. That is why the handwriting is also very important. Then all medicines should be checked for name and expiry dates before dispensing. This is pharmacy's responsibility, as well as when the drugs come to you, the staff nurse always, along with the inventory, she can check for the name and expiry dates. Then pharmacy is responsible for proper labeling and packing of the drugs. And nurse should check that known drug allergies are highlighted so that patient does not receive that drug. So anyone who comes and orders the drugs know that when he or she sees the highlighted things, that person knows that this patient is allergic to these drugs. They can be either highlighted, they're written in red ink, or they're written in bold letters. So that can be done. So that was about the storage. Now regarding reducing errors in high risk medications. So as far as possible, the high risk medications, they are not stored. Only when required, they're brought and used. And when you have it, avoid storing look like and sound like medication next to each other. So in previous slide, I mentioned that drugs can be stored as per alphabetical order. But if you have a confusion, like one example I have quoted here, the injection vincristine and vinblastine, which are chemotherapeutic drugs. So these are sound like medications. So instead of this using generic name, they can be stored by using their brand name. Instead of vincristine, you can write it as oncovin, and instead of vinblastine, you can write it as Velban. So if I mean, it depends of course on the hospital policies, but certain changes can be made. And always there has to be a register of high risk medication in which the name of the person from whom the medicines are received is mentioned, quantity is mentioned, balance, then sign of the person who makes the entry, and sign of the person who checks for all this. So the register, there will be register which will include all these things. Then how do you reduce the errors during administration? So all the rights of medications which are already mentioned by the previous errors, there were basically 5 rights. Now it is 10, 12, whatever rights, all those are checked. Then administration by only authorized healthcare professional. Then already prepared medications are named, dose and timing. Sometimes the patients are on drips. See, for example, dopamine, you want to give it in through a syringe pump, so you maybe dilute dopamine with 50 ml of normal saline or 5% of dextrose or whatever as per the orders. And then you know that that previous syringe is going to get over within 5 minutes, so you prepare the next one and keep. So when you're already preparing, immediately without any time wasting, you will name it, the name of the medicine and dose, at what time you will be starting. So all those things should be immediately put on the syringe. Then medication should be checked for name of the patient, name of the medicine, dose, frequency, route. Then verification by at least 2 people, especially for high risk medications. Then the documentation, of course, this is important part, because whatever you give, if you're not documented, that means you're not given it. So documentation immediately after administration. Then in case the drugs are brought from the outside organization, usually these such things are not allowed, but if at all in that particular organization some drugs are not available, in that case maybe the drugs are got from outside. So in that case, one has to check for the bill, the correct name, the label of the drug, the dose, expiry date. So staff nurses can always check for that. And also encourage patient to be actively involved in medication process. So you are aware, as well as make patient also educated about like what drugs he's getting, what can be the timings, what are the doses. So make patient also aware, so involve him in the medication process. These are the some example of ambiguous nomenclature. Now, usually Tegretol, that last L and the dose 100 milligram, that one can be a confusion. It should not be Tegretol 1000, Tegreto 1100 milligram. So when the things are written, one has to be very careful how it is written. SC, there can be confusion between sublingual and subcutaneous, SC and SL. Then 1.0 milligram and 10 milligram. When it is only 1 milligram, avoid writing 0. Why you want to write 1.0 milligram? That can be interpreted as 10 milligram. But when it is 0.1 milligram, always try to write 0.1, because 0.1 can be interpreted as 1 milligram. So such things can be followed when the medicines are prescribed. And of course, these are the ways where you try to reduce the medication errors. Now, what can be the risk if at all medication error occurs? What can be the risk? So the one major risk is there can be adverse drug reaction. So what is an adverse drug reaction? It is a response to a drug which is noxious, and unintended, and it occurs at doses normally used in human being for the prophylaxis, diagnosis, or therapy of disease, or for the modification of physiological function. Now, what are the risk factors for this adverse drug reaction? Age is one important factor because very young and very old, they are at risk because very young, the all systems are not developed. The liver is not able to metabolize the drugs. The kidneys are not yet completely developed so that they can excrete the drugs. Or in old age people, maybe the systems are no more functioning, and that is the reason why young and very old are at risk of adverse drug reaction. Second is, of course, heredity, and then simultaneous use of several drugs, and pregnancy and breastfeeding, as many drugs can be passed through the placenta membrane and through the breast milk. So these are the risk factors for adverse drug reaction. Now, types of adverse drug reaction, they can be either dose related or allergic, or sometimes you don't know exactly what reason is. So they come under the category of idiosyncratic adverse drug reactions. Dose related, that means when you give too much high dose, say for example, antihypertensive drugs, extra tablet is given, then patient feels giddy, or when you give extra dose of insulin, in that case also patient may fall, the blood sugar level goes down and patient feels giddy and fall down. Then allergic drug reactions, when there are problems with the immune system, so in that case allergy can occur. Or as I said, when you don't know the reason, exact reason, but there will be something like nausea, diarrhea, some rash development, so in that case they are categorized under the category of idiosyncratic adverse drug reactions. Then there is severity of adverse drug reaction. Of course, there is no WHO or any institutional classification for severity, but overall the severity can be classified as mild reaction, moderate, severe, and lethal reaction. So for mild, in this case, the drug need not be stopped, but of course, drug frequency or timing can be re-evaluated, or some other drugs may be used to control the symptoms of adverse drug reactions. For example, stool softener can be given for constipation. Usually, some drugs like when you want to increase the hemoglobin in case of anemia patient, so all those drugs will cause a constipation. So for that, no need to stop the drug, but instead of that, stool softener can be given because you want to increase the hemoglobin level of the patient. And there can be some common mild reactions like headache, nausea, constipation, diarrhea, fatigue, and malaise. Very common with especially antibiotics, fatigue, malaise, vague muscle aches. There may be changes in sleeping patterns, but these all are considered as mild reactions. Moderate can be like there may be skin rashes, muscle tremors, visual disturbances, changes in mood or mental function. There may be decrease in white blood cell count or blood glucose level. These are examples of moderate reaction. Then there sometimes the reactions can be severe. They are relatively rare but can be life threatening, such as liver failure, changes in heart rhythm, may result in persistent or significant disability. And these are the severe reactions, and at the end this reaction can be lethal, that is drug reaction directly or indirectly cause a death. So these are the examples of reactions: mild, moderate, severe, and lethal. Then how do you treat this adverse reaction is either you modify a dose or discontinue drug, or switch to a new drug, some different drug. Now, what can be the impact of this medication errors? Now, this impact, it ranges from no effect to long-term disability or death. So, health status of the patient is important. Along with health status, there can be financial implications on the patient, because naturally, if it is a disability, then maybe there may be prolonged hospital stay. Naturally, the cost increases. Sometimes the cost is not reimbursed by insurance, so all these financial implications can be there. And the patient may lose the trust of the institute, and will try to switch over the institute for medical help, or a person or patient may even seek non-conventional methods, like he can opt for some alternative therapies. Now till now we have seen how can you reduce the medication errors. Now, what actions can be taken when medication error occurs? Now, when medication error occurs, the responsibility can be with consultants, nursing staff, or pharmacy. One of the previous speaker had shown one of the research where the maximum percentage was seen with the nursing staff. The responsibility was with the nursing staff. So all these can have the responsibility, but top priority is patient safety. What has to be done is immediately when nurses are always in close contact with the patient, so they can identify the errors. So immediately assess and examine the patient's condition, notify to the physician and immediate superior nursing personnel. Maybe there may be ward in charge in the ward or ICU, wherever, whichever area you are working. So notify it to them immediately. And once the patient is stable, the report it to the appropriate person, that is nurse supervisor or nurse manager. It has to be reported. And later on, the incident report is made, and this report is made before your shift is changed, or at least within 24 hours of incident. And this one copy is submitted to pharmacy and therapeutic committee chairman. Usually all hospitals, they will have the therapeutic committee where the pharmacy and the other administrators are the members of the committee. So the report is submitted to the chairperson of the committee. Now, one should not get scared of this, but this reporting requires knowledge to recognize the error, also the confidence and communication skill to address the error with appropriate person. Now, many all accredited hospitals, maybe it is NABH or JCI, whatever accreditation, they have the policies. They have very well defined policies for management of medication, and all these policies will define exactly how do you give the medications. So one part is they define the medication error also, and types of medication error, whether it is when do you call it as order error, when do you call it as transcription error, or when do you call it as a preparation error, and when do you call it as administration error. So based on these policies, the report can be made. Now, this incident report, it may not be a part of medical record, but it's a document, it's a legal protection for employee and institution. This report is a part of quality improvement program, and which is usually used to track the incident pattern. In fact, it is a part of good management, risk management program. Now, when you make a report, there are certain things which you mention in the report. So part of this medication error report are, one is demographic details of the patient, time of the incident, location of incident, accurate factual description of the incident is given, and details of the employee, details of the person who fills the report. And then later on, maybe the course of action is mentioned in that. The course of action depends on the details of the error. What type of error is made, the course of action depends on that. And the committee will make a root cause analysis. So the steps of root cause analysis are usually these. You establish a team of appropriate personnel, describe event in detail, find exact cause, develop specific action plan, and develop outcome measures. So all the members of this committee, as I said previously, they will sit together. The person who has committed the error will be taken into the confidence. All the whole incident is discussed in the committee, and all these things are done at very confidential level without exposing the person's names. And based on that, the corrective action plan can be taken. Say for example, corrective action plan is like, if a minor mistake is done, maybe the person is the area where the mistake was done, that the person is taken out from that area, and some other area he or she can be posted. Or for some days, the person is not allowed to give the medication. It is not necessary that always you remove the person from the job. Such things also can be done. Change the area, and for few days the person is not allowed to give the medication. The retraining is given to the medication, related to medication can be given to that particular person. The re-evaluation is done, and after a few days the things can be continued as normal. So there can be emotional impact of these errors on that particular person, but it should go smoothly. It may lead to isolation, doubt in one's ability to perform well in future. There may be loss of confidence. Post error counseling can be done. Medication error prevention training can be done. As I said, corrective actions can be taken, and focus on job related stress reduction, reduce the incidence of feeling guilty. Then there is something known as National Coordination Center for Pharmacovigilance Program of India. These are usually, they advise you how do you report, what to report. Like they say that serious as well as non-serious drug reactions are should be reported. Who can report? Any healthcare professionals, the physicians involved, the treating doctor, or the staff nurses. Any one of them can report. Where to report is adverse drug reaction monitoring centers. There are always local adverse drug reaction monitoring centers are there. So first the reports are sent to them, and they always tell you what happens to submitted information. The casualty assessment is done at adverse drug monitoring center by using WHO UMC scale. UMC is that Upasala monitoring center is there, which is coordinated by WHO and which is located at Sweden. So, so they have a scale, and with the help of that, all confidential handling of the information is done, and follow-up is taken about the incident, whatever has happened. And there are certain mandatory fields in this ADR report, that is the patient's initial age of onset, the onset of reaction, the reaction details, date of onset of reaction, and suspected medication, reporter information. All this is taken. Actually, this is basically to explore and understand the risk and benefits of medication. So all those NABH accredited hospitals, they usually, what do? They report this, they send these reports to local adverse drug monitoring reaction monitoring centers, and then they may send it to UMC, Upasana Monitoring Center. So in the end, I'll just say that medications errors can be costly in terms of money, time, and health status of the patient. But education is the only key to prevent the medication errors. So there should be, see, human beings, it's very natural for them that they forget the things. So repetition is the only key so that you remember the things. So that can be done through the regular in-service education programs. The staff nurses should not feel that it's a punishment. The in-service education program is a punishment for them. It is not that, it's just a revision for them. You know the things, but sometimes it may happen you're forgetting. Like you forget some drugs, names of the drugs. There are few new drugs which are available in the market. So through in-service, you come across with those new things, and then you're revised about the knowledge. In areas like ICUs, the operation theaters, what can be done is like the easy access. If at all a staff wants to know certain details of the drugs, so maybe internet facilities or something like drug books should be made available to the healthcare professionals. So in case they have any doubt, they can immediately refer it. And discussion is also one key, where you can always discuss the things with your colleagues. When you discuss the things, what happens, you become alert. You know that, okay, previously somebody has done this mistake. So when I'm giving this particular drugs, I should be alert. I should not make this mistakes. So discussion is always helps to gain the knowledge. And this is how or certain information like certain drugs are not crushed, they're only swallowed. So such things are displayed or highlighted in area where they're easily seen by the people who are working in the hospital. So such things can be done. And these are the various ways how you reduce the medication errors, and what you do in it all, if at all you do error, what can be done. So these are the references, and thank you. So once again, thank you to Vikrant Institute and Professor Keshkali for giving me this opportunity.
Thank you so much, ma'am. Really, it was very informative and practical session for day-to-day practice. By listen your session, I come to know that this is the topic which should be discussed rigorously and periodically, because most of the nurses and due to, it may be because of their busy schedule, they've forgotten to follow certain specific orders. Yes,
Yes.
ma'am. So I feel that again we should organize every year somewhere, either this college or that college, we should organize and give exposure to our beneficiaries, our students, our nurses, our teachers to get acquainted with this topic. And they should, even for teachers, if teachers will learn these things, they can share this with their students, and students who are future nurses will practice with judicially this topic.
Right, exactly.
So thank you so much, madam.
Thank you.
And if anybody have any question, you can ask. This was very fruitful and practical session for you all. I feel personally that you should have many questions.
Somebody had asked regarding the emergency. So what I thought, maybe like as I said, the telephonic orders can be accepted. Only thing they have to see that they're getting, yes, it should be written down later on as soon as possible. That can be done.
Yeah. Thank you so
As
much,
madam
madam.
said, we are not exactly involved in ordering, but that can be accepted and then given.
Okay, thank you, ma'am. Thank you. We have our Assistant Managing Director, Dr. Sandeep Shukla sir with us. Sir, kindly acknowledge the talk of madam and say a few words. Dr. Sandeep Shukla sir. Sir, can you hear me? Sandeep Shukla sir, can you hear me, sir?
Yeah, ma'am.
Yes, sir.
Good afternoon, one and all. First of all, I congratulate Keshali ma'am to organize a wonderful national level workshop conference. And the topic was very necessary to understand everyone. Everyone is want to know that error should not be there in medication. So I thank you, Sadhna ma'am, to share such a wonderful thoughts with us and nursing fraternity. And I also thank to all the nursing people and doctor people who done a wonderful job in such a pandemic situation. You guys are very good in very great working. So I thank all of you, and thank you very much, Sadhna ma'am, to share this kind of such a little bit things to our all nursing professionals. Thank you, ma'am.
Thank you, thank you.
Thank you, sir. Thank you so much, sir. Rightly you
Thank you.
said, sir, during this corona pandemics, nurses are considered as frontline warriors and caregivers, and their responsibilities are increased, and they should learn and they should practice these things. Thank you, Sadhna madam. Thank you so much. Now we have our next speaker with us, Mrs. Dolly Viswas from Fortis Hospital, Calcutta. I request madam to please start with your session, which is very important again for practicing nurses. The topic is nurses' role in the prevention of medication error. Madam, please proceed with your topic. Madam Dolly, over to you, madam. Dolly ma'am, can you hear me? Madam is connecting. Till that, I want to inform you all that to getting e-certificate, it is very essential to all the audience and participants to please fill feedback form and submit it. Dolly ma'am, you can unmute yourself. You are co-host, so you can unmute yourself by your own.
Dolly
डॉली विश्वास को बोले बना दो. Wait, Dolly madam, we are making you co-host. Actually, we have two Dollys. One is Dolly John and you are Dolly Viswas. And by mistake, we had made host to Dolly John madam. Soon we'll make you host.
Hello.
Yes, yes. Dolly ma'am.
So is it by Dolly John madam or I have to speak?
No, you only. Actually, our
Because
host by mistaken he has made her co-host.
Okay, my session was at 3 to 4 p.m.
It is your session, madam. It is your session. Dolly Viswas session.
Okay, okay. So I have to share my slide.
Yeah,
so just let me take through the slide.
Yeah. You can take your own time, madam.
Give me 2 minutes. Give me 2 minutes.
Okay, madam. You can take.
একটুখানি দাঁড়াও না আসলে these slides are there in pen drive. So share. এখান থেকে Okay, can you see me? Can you see me?
Yes, nicely. We can see you. We can visualize your slide also.
Thank you so much. First of all, it's my proud privilege to take this session today along with this all gathering, and I am seeing there is a huge people have been connected, the students connected, almost 600 students, and the credit really goes to Madam Keshkali, who is my friend, my batchmate, and we all, both of us studied together in Indore College of Nursing, and I am proud to present this session today to share my thoughts to your student, and I'm glad that you have organized such a wonderful conference and virtual conference where everybody have connected and participating and very well spoken by many of the speakers before me. So now I would like to take through without spending much time, and welcome to all the students, principal, and the other faculty who have connected. So let me take to the slide, role of a nurse in preventing medication error. And I am working in Fortis Hospital, Kolkata, Anandapur. I am the chief nursing officer over here. So the next slide, the objective of today's session, this particular topic, to create safe environment for patient. Ultimately, patients when are coming to us, we have to take care of them. We have to provide them a safe environment, and we have to see that we should not do any harm to the patient. That is the primary objective which we have to keep in mind. Next is promote safety culture in the organization. Third, to motivate the staff for safe administration of drug, to prevent adverse drug reaction, to gain customer satisfactions, that is our patients and their relatives, and to develop competent caregiver, which is most important role today a nurse leaders must play. In any of the healthcare organization, as we all know, 60% populations are the nurses, rest of 40% are comprises of other supportive staff. So why do we say the nurses are the backbone of organization? Because of this, because any organization nurses are comprising 60 to 65% of the population, and there are plenty of responsibilities lying on us, and medication administration is one of the most important responsibilities that we all have to keep in mind. As you all are hearing long lectures from many of the speakers, there are the errors that happen. Prescribing error, almost 39% that has been reported worldwide, could be a wrong dose, wrong choice, known allergies related to error, 6% wrong frequencies, 4% drug-drug interaction, and 2% wrong drug administration. Transcribing error, doctor while transcribing into the medication card, or a nurse has got the power to transcribe the medication card, at that time the error can happen. That is illegible signature, time missing, order incompetent, or order illegible. So these all are the problems, and percentage wise the study is being done. Dispensing error, 11% error happens mostly, and because of that, dispensing error may be from the pharmacy, decimal point error or calculation error, dosage misdivided, the staff doesn't know how to divide the dose, or doesn't know what formula to be used to calculate the infusion when a patient is on inotropic infusion or vasodilator or any kind of other infusion are going on. That time the staff has to know about it, that how the formula, which formula to be used to calculate, and dosage not divided properly are causing a dispensing error. Maybe from pharmacy also it could happen, and administration error, which is 38% almost, can happen because a nurse have administered in a wrong way.